Raman sir. Dr. T.V. Ravi is the President, NNF Kerala 2021, and the Senior Consultant Neonatologist from Ernakulam Medical Center. And Dr. T.P. Jayaraman is the President, IAP Kerala 2021. He is the Senior Consultant Pediatrician from Palakkad. And first, we have a panel discussion on neonatal emergencies. I request Dr. T.V. Ravi sir and Dr. T.P. Jayaraman sir to kindly introduce the moderator as well as the panelists for the talk and to lead the session. Thank you.
Good evening, friends. I think it's a great privilege to have the President and Secretary of IAP amongst us because IAP and NNF are the same family. So I give the honors to Dr. Jayaraman to start the proceedings. Jayaraman?
Unmute, Jayaraman sir, please unmute. Please unmute.
Good evening. At the outset, let me thank the organizers for having given me an opportunity to chair this inaugural session of this program along with my friend Dr. Ravi. And I'm sorry that I may have to leave in between due to some personal issues. So the first session is on neonatal emergencies, which is an integral part of neonatal practice, that is management of a newborn in emergency situations, and stabilization is the important component of any neonatal practice. And we have a session organized, a panel discussion with some expert panelists under Dr. K.K. Divagar, who needs no introduction for this audience. He is one of the senior most neonatologists, as well as a very good friend of mine, who is the Dean of the Kolanchery Medical College. And the other panelists, Dr. Jacob Abraham, Dr. Jayachandran, Dr. Rijo, and Dr. Shanavas. I think none of them need an introduction for this audience. As a formality, I request Dr. Ravi to proceed with the introduction of the panelists and the moderator. Thank you so much.
Hello, Professor K.K. Divagar doesn't need an introduction. It is customary to give a formal introduction in any academic forum of this nature. So I consider it my proud privilege to introduce Professor K.K. Divagar, Dean, Professor and Head of the Department of Neonatology, MOSC Medical College, Kolanchery. Professor Krishna Divagar is an alumnus of the Armed Forces Medical College, Pune, India. Having obtained his postgraduate qualification of DCH, DNB and MD from Kerala, he has had his training in neonatology at the prestigious Westmead Hospital, Sydney, in 1990 to 1992 in Australia. Subsequently, he joined us Faculty of Neonatology at the Kasturba Medical College in Manipal, Karnataka, and was heading the Division of Neonatology from 1995. Dr. Divagar continued as Professor and Head of the Department of Neonatology at the same institution until he joined the MOSC Medical College in 2003 to establish the Department of Neonatology here. Professor Divagar was the recipient of the Fulbright Visiting Lecturer Fellowship for the year 2002 and was awarded the fellowship of the Royal College of Pediatrics and Child Health UK in 2007. It is a great honor that his unit has been accorded the DM Neonatology course a few years ago. It's indeed an honor to have him amongst us today evening. I request you, sir, to introduce your panelists and take forward the proceedings. Thank you, sir.
Thank you, Dr. Ravi. Am I audible?
Yes, sir.
I think as we have done in the past, I'll just leave it to all the panelists to give a self-introduction to those who are not familiar with all of us. The chief will be the carnivore of the team, Dr. Shahnawaz. You can please take over and we'll just start off. Dr. Shahnawaz, please go ahead.
Sir, good evening, sir. Thank you for taking me as a panelist. I'm Dr. Shahnawaz. I'm now working as Professor and HOD, Department of Pediatrics, TDMC, Chalappuzha. I graduated from my MBBS and MD from Government Medical College, Trivandrum. I was working as a faculty from 1998 onwards, and now I am a professor in TDMC, Chalappuzha for the last 3 years. Thank you.
Dr. Jacob.
Good evening. Good evening, all.
Yes, a little bit louder.
Yeah, good evening, all. Thank you very much, sir. I'm Jacob Abraham. I have been working in Pushpagiri since 2006, and presently I am looking after not just neonatology, but also pediatrics as the professor and HOD of pediatrics. I finished training with Dr. Divakar, and before that, I am an alumnus of CMC Ludhiana, and I had a year's fellowship training with Divakar, sir. Thank you very much.
Dr. Jayachandran.
Very good evening to all. Greetings from Island of Malappuram. It's indeed an honor to do a panel discussion with Divakar, sir. I am neonatologist working at Neobliss Maulana Hospital, Perinthalmanna. Thank you.
Rojo.
Good evening to all. First, answer, let me thank organizers for giving me a chance in this particular panel discussion, especially with Divakar, sir. I'm working as a neonatologist in Luth Hospital, Kochi, and without wasting much time.
Thank you all. I think our mics are all right. I was just testing that. I think Jacob, you'll have to put it slightly closer. All the others are fairly well audible. Yeah. Okay. We won't waste. When we talk about emergency or critical care, it reminds me of a Sanskrit shloka. It says, Akriyat dhruvam mrityu, krayat samshayam bhave. That means if you don't do anything, death is inevitable. But if you do something, you might be able to salvage. Now, this is what is told in as far as critical care goes in Sushra Samhita. But the interesting part is in neonatology, everything is critical care and everything is emergency. So it was a very difficult task to know what is emergency in neonatology. And my task was reduced significantly by Dr. Jacob and all the panelists who decided that we will take those things that have not been given priority in the seminar and take out those, discuss those topics. Some may not be so acute in emergency. Nevertheless, we'll quickly go through some of those topics so that some light can be shared. Also, the rules of the discussion is very clear-cut. We want to make it interactive. At least the senior panelists whom we can actually see, you're welcome to raise your hands and put in your comments. So we don't want to restrict to a monotonous monologue between the 5 of us going on here. And if somebody can monitor the chat box for me, I'm sure that'll be nice. If some questions come, if time permits, we'll go through it. So without much ado, let's start off with a very simple clinical scenario. We have a delivery which is of term twins delivered by cesarean section. And the postnatal nurse says that the babies are having some respiratory, one of the babies having some respiratory distress. And there's a lot of oral secretions with difficulty in passing the gastric tube. A scenario which is not at all uncommon, familiar, and I think Dr. Jacob was very interested in discussing this scenario. Jacob, over to you.
I think from the diagnosis and from the fact that the catheter was difficult to be passed, I think the diagnosis is fairly evident to most of us who are practicing newborn care. And usually in the setting of a polyhydramnios, a baby who is drooling or having copious secretions.
Yeah, this is where I wanted. I'm glad you said this because I didn't mention polyhydramnios. Purposely didn't mention it. So for all the resident doctors, the word polyhydramnios is extremely important. So the moment you get somebody with polyhydramnios, start thinking of all these things. Okay, thanks, Jacob.
Okay. So usually what we would probably again look at in the antenatal period would not just be polyhydramnios, but also sometimes you might be able to make out a prominent stomach bubble, which again will probably tell you that it is because of a dilated distended stomach with a connection between the trachea and the distal part of the esophagus. So that may sometimes give you an idea of what type of fistula it is. And mostly the diagnosis is made by passing a thick catheter, and the catheter which is passed through the nose or probably through the oral cavity will reach the blind end of the pouch. And usually, because we are using an NG tube, which is not a very rigid tube, it will either come back or return back through the mouth of the baby, or we might sometimes feel an obstruction. The obstruction.
Jayendran, do you think it's always reliable just to put a catheter for tracheostomal fistula? Because there have been many anecdotes in different ways. Anything you want to do subsequent to that, just passing a catheter to restrict? Jen, adding comments onto it, you are supposed to be the...
I think we should do an X-ray. If we have suspicion in having passing an OG tube, better do an X-ray instead of trying repeatedly. Because this is a condition, even though absent stomach bubble is an important sign, this is a condition which is commonly not picked up antenatally. Most time, even when we are speaking
to pediatricians. How clear is this X-ray, when you take it? Because one of the suggestions we used to say, just pump in about 2 ml of air, because then the contrast comes out very well. Otherwise, people generally don't see. And most important thing is people should think of it. Only then you think of tracheostomal fistula. We have had occasions, I must confess at this stage, we can confess to all errors. We have had occasions where babies have been fed with tracheostomal fistula, and then after some time realizing that something has gone wrong. So it's not uncommon. So
definitely not to feed, and make sure that secretions are not getting aspirated. It's also very important. Keeping head and elevated, and if your center is not having facility, refer early.
Okay, Jacob, please go ahead.
And probably the cardinal rule that every resident or person working in newborn has to understand is that the tube is absolutely important. It's important that we get a gurgle after having placed a tube, ensure that it's in the stomach, hear a gurgle, and then only be sure that there is no esophageal atresia. And that is the reason why, as Dr. Jayendran rightly pointed out, an X-ray probably would be confirmatory. If you are able to not pass a tube and not able to get a gurgle, it might be, overdoing it, but then it is safer to pick up an esophageal atresia rather than have a baby with an aspiration. And if you have found out that the baby's NG tube is not going into the stomach, you've confirmed with an X-ray, after which you make sure that the baby is either managed in a place where the baby is going to be operated upon. So it is best if you have a pediatric surgical setup to involve the pediatric surgeon, or like Dr. Jayendran said, if there is no pediatric surgical help available, ensure that you safely send. While you are stabilizing and sending, ensure that suction of the upper esophageal pouch be made, because that is the usual common anomaly that you will see is one where you have a blind.
How do you do it? What is the position you would like to keep this baby in? One query. And second thing is it necessary to intubate these babies all the time?
It might be wiser to intubate, because you would have then definitely protected the airway. But sometimes it is, if you can't intubate, you may just kind of be able to get away with suctioning the baby and ensuring that the tube is always kept at a minimal negative suction. So
I have a query here. I wanted to question. I think Dr. Shanawaz is also there. Please drop in. You see, because when you intubate the baby, you have got the air that is going into the trachea, isn't it?
Yes. So the problem of having to go distal to the, keep the tube end distal to the possible area of, this thing of your fistula. That is something that might prevent air from going into the stomach.
Yeah. So this is probably one of the places where we don't have it too worried about carinal position.
Yes.
Yeah, and yes. Great. And what about any position? Any position you would like to keep this baby in? No.
It is obviously better to keep the baby a little flat or down, so that secretions are kind of pulled into the oral cavity and taken away. And I don't know whether any particular position.
I think flat or down is that the general feeling? I don't know whether any second opinions about it.
Lateral position will be ideal, sir.
Okay. And what about the inclination? Should it be down or elevated?
Should be elevated most ideally.
Yeah, because one of the comments which people make when you put flat or down is the secretions will come out and that tend to aspirate, because there are a lot of secretions. So when the first point, Jacob, what you told about continuous aspiration is present, at that position, if you keep it inclined slightly laterally and elevated, then the suction takes care of the rest of the thing. Sometimes when you put it lateral and down,
agree, sir.
Gastric secretions may also come through, which is the biggest worry we have got, right into through the fistula. Great, Jacob. Any other comments on this? And
I think
The other, okay, sorry, I needed to add another thing is that about the fact that there could be an associated vector. So always think of an association because it is part of a vectoral association. And there have been instances of children being focused on for the esophageal atresia and also ending up with having an anal atresia. So that is something that we need to kind of rule out because
yes, Jane, you were saying something?
Yes, even after surgery, this GER is very common in this type of cases. And even later, they can present with the esophageal stricture during at the time of weaning. And surgeons used to say that sometimes they end up in dilating the esophagus. So reflux is very common, which way to always anticipate in this type of scenario. And one more thing I want to add, the one common problem they can have postoperatively is anastomotically with the aspiration pneumonia.
Because we are having about 8 topics. That's why I'm sort of rushing through. Have I missed out anything, Jacob, or you want to add something more, or can we?
Yeah, I think.
There's a question in the chat box, sir. Is Replogal catheter available in India?
Sorry, I didn't see that. What catheter? Sorry, I didn't see.
Replogal catheter.
Replogal catheter is sometimes not available because I mean we've used it in Delhi when I was working in Delhi, but then that was something that was got across by the pediatric surgeon and we were using it there. But the idea is basically to try and keep 2 catheters together so that one will allow the air to come in and the other one would be used as a suction. So a parallel tube wherein one is an air port and the other one is something to use for suction. So that is probably something which we can devise, but the problem is because of the secretions, you can't stick it together. So that is something we need to be careful about. The other thing that I wanted to add along with what Dr. Jayachandran said is about the fact that post-surgery, the surgeons are very particular about fixing the NG tube. You should be very careful not to reinsert it because that is an instruction that they usually tell you to not to do. They should be involved whenever you need a NG reinsertion. Babies might pull it out. Most of the surgeons I worked with stitched the, NG tube to a place.
You'll be very unpopular with the surgeon if that happens, especially in the first 48 hours. So that is why the biggest fear I have is when I intubate such babies. Because a choice comes sometimes if you get a tube block, how to re-intubate, because the stretch happens.
It's again the problem.
So it is a terrible situation. And as far as possible, if somebody can, we don't have to intubate and you do the extubation very early. That takes care of a lot of problem because the lung is not damaged. You should not unnecessarily keep this baby on a ventilator. The re-intubation is going to be a real horrible thing. And with every suction that you do, there's always a trauma of something happening. This is a word of caution. And now we have a situation where, we are very happy. The first twin has been diagnosed, comfortably managed, and we are happy with the second twin is doing well. But then after about 8 hours, the nurses noticed that there is the other twin, which everybody believed was all right, is having some difficulty in sucking, and saturation in air is about 92%. And nurses are complaining that pulse oximeter probe is not working because episodically they are seeing that the waveform looks very funny and the heart rate is going somewhere around 200, very often under 200, and now it's been elevated and continuing to be about 200. Everybody was concentrating in the ICU on the post-op case. And obviously it comes to HOD and poor Dr. Shanavas is on call that day and he gets a call. Over to you, Dr. Shanavas.
So, thank you, sir. Here there is a baby, second of a twin, day 1. First 8 hours child was normal. Now showing intermittent tachycardia. That is, heart rate is more than 200, and subsequently now resistant tachycardia. And there is some tachypnea and also some poor feeding. So here, the first thing in any tachycardia is we should consider is a sinus tachycardia. So it could be due to hypoxia, hypovolemia, like that. So once you have got a tachycardia patient, the first thing you have to do is you should go for an ECG. So the close differential diagnosis is SVT, or supraventricular tachycardia. So as we all know, the sinus SA node is unlikely to be higher more than 200 beats per minute. So whenever you see a heart rate of more than 200, you always suspect SVT. Along with that, there are 3 or 4 other features. That is a P wave that is usually absent in 50% of SVT patients. And also, if it is present, it will be normal in axis or abnormal in shape, or it will be coming after the QRS complex. If it is like that, you should consider the first diagnosis as SVT instead of sinus tachycardia. Here comes the management. You have to rush now for the management option. So you have to decide on two things. Number one is whether there is some hemodynamic compromise in the form of a congestive cardiac failure or hypotension is there. If it is not there, so here there are some features like a patient is having tachypnea, a desaturation of 92% saturation, and also there is some other features. So first thing you have to give is you give oxygen, and you can consider a reconversion or going back to sinus ways to make the rhythm to sinus rhythm. So the first thing you can do is some form of vagal maneuvers. So you can crush ice pieces into a polythene bag and apply about 10 to 15 seconds on the face. So that will be doing good in some cases.
Rojo, your comments on that?
Sorry, sir?
Your comments on the ice pack on the face?
Vagal maneuver.
Vagal maneuvers.
The only problem is like sometimes it may be harmful to the baby if you apply directly the ice onto the baby. Sometimes the injury can happen, sir. So I've seen 2-3 babies who had in fact a cold injury to the face by the direct application of ice on.
I remember Dr. Vishnu Bhatt saying something like that. That is why I asked you.
Yes, sir.
He used to always
apply directly. It should not be applied directly.
Yeah, that's exactly.
Yeah, recently I saw a baby who had an injury to the face applying because he had a scald injury over here.
So that Dr. Shana has already covered that point. That is something I wanted you to highlight, that it should not be applied directly. People may take the ice and just put it on the face. So that is something. Thank you, sir. Please continue, Dr. Shana.
Okay. So if it is not the vagal, other maneuvers like carotid massages is not at all used nowadays. But if it is not reversing, so you can go for the direct medical therapy, that is giving adenosine. So for regarding adenosine, you have to select 4 important things. Number one is that you should select preferably a big vein near to the that is antecubital vein.
Can you please mute those who are on the line? Please mute the who are not speaking. Thank you. Please go ahead, Dr. Anas.
So the second one is you have to be ready with resuscitation equipment. So atropine should be ready, aminofilm should be ready, so that sometimes there may be some undue effect. A cardioversion should be. You have to do all these in a facility where these are available. So you put a cannula in the antecubital vein, connect to a 3-way, and one port you should connect adenosine, the other port normal saline should be connected. You should start with 0.1 milligram per kg of adenosine and give us a rapid push followed by a 2 ml saline push, so that it reaches very quickly to the circulation. So if it is not reverting at this point, you can double the dose to 2 milligram, 0.2 mg and also 0.3 mg. So all the three, you can give a maximum 0.3 mg per kg of adenosine can be tried. If it is not reverting, you can go for other things.
I always have a comment about when we tell, when we really have to tell the residents when we mean the rapid is a really, really rapid push. Because you have to push one and the other one, it should immediately go. There is no, the nurses or actually it should never be given the nursing surgery. We believe it should be given by the doctor himself there. And once you give it, the whatever is your, the supplementary push that you're giving with saline or whatever it is, it has to go immediately after that and as fast as possible, not a slow push, which we normally do to save a IV or give a hep lock. So that rapidity is something which I think we have to demonstrate whenever we get an opportunity to show people, because the textbook never tell you rapidity. One of my professors used to say, don't pour the acid into water, don't pour water into acid, you have to pour it. You know? So that sound actually makes you feel how slowly it has to go. So here it has to be pushed, not pushed.
Yes, that's right, sir. Yeah, agree.
That's great. But what is the problem when you give adenosine? Does something else happen when you give adenosine? Any other issues can happen with the cardiac rhythm?
So one thing is there is a sudden cardiac arrest can be because of the SA node get temporarily blocked and can subsequently lead to cardiac arrest. The second thing is adenosine. You know, the adenosine is one of the mediator of asthma. It can precipitate asthma. So both these conditions you should expect, you should have suitable precautions to prevent that.
Roger, would you like to comment something? Unmasking when you give adenosine.
Atrial flutter can get unmasked, sir. Atrial flutter can get unmasked when you give adenosine. If it is in a flutter waves is there, sometimes if you're blocking the AV node, in that point of time, atrial flutter may get unmasked.
Yeah, because one of the things I also knew, I was talking about SVT till I talked to one of the pediatric cardiologists. That's why I gave this topic directly to Dr. Shahnawaz, and I didn't ask him any question because I don't know anything much about it. So it's fantastic to believe that except for this, a lot of the aberrant pathways get activated. Sometimes when you get adenosine, and then the whole line of treatment goes off. So you really have to cardiovert and really ask for help from the pediatric cardiologist how to handle it. But straight away, obviously, you'll have to give adenosine primary topic, and then subsequently see whether you can stabilize it if you are capable of doing cardioversion there. Any comments you would like to make on the number of joules and whether it was synchronized, asynchronized, and all that?
So there are 3 indications for giving cardioversion. Number 1 is to start with, it is hypotension, and there is a features of congestive cardiac failure, moderate to severe congestive cardiac. Third point is if the adenosine get fails, also you can go for DC version. So DC version is, I will start with always synchronized DC version, 0.5 joules per kg, maximum is 2 joules per kg you got. So in as we all know, there are so many 3 main types of mechanism for development of SVT. Number 1 is re-entry mechanism. Number 2 is automatic tachycardia, and third is triggered activity. So except in this pathway through the AV node or accessory pathway, all other pathways may not be respond to adenosine. So in that case, you may go for cardioversion. So the third thing, once the patient attain a normal cardiac tracing, is you have to go for an ECG. A routine ECG should be done immediately, and you should decide on whether there is any WPW syndrome present or not. So that is the most important thing. When the conduction, AV nodal, AV accessory pathway conduction through a concealed or a revealed pathway like WPW syndrome is there, you are not supposed to give further management with digoxin or calcium channel blockers. So calcium channel blockers generally not indicated in newborns, but you are not supposed to give digoxin also in a case of WP syndrome. The 3 main features of WPW syndrome are short PR interval, a delta wave, and a wide QRS complex. If it is there, it is a WPW syndrome. You have to start him for a beta blocker, preferably propranolol is usually we used to start, and you maintain those things.
Roger, you want to add something?
Sir, Dr. Shahnawaz sir has already given a detailed description of SVT. So only one thing, sir, because children who come, the newborn who come with SVT, it may be very difficult to get a peripheral IV line because they may be in shock. So the best thing would be to put an, if at all, in a UVC. And that in that case, adenosine works fantastically also because you're giving directly to the central line. And if it is correctly pushed in UVC, the adenosine works finely with the first dose itself. You may not have to give a repeated doses. And sometimes if the adenosine fails, as an acute treatment, we may have to go with amiodarone infusion as one thing that has been recommended as a 5 mg per kg loading dose over some 30 to 60 minutes. And thereafter 5 microgram per kg per minute, depending upon the clinical scenario. And as sir mentioned, depending upon the thing, you will have to, sometimes you may require a chronic treatment. Ideally with the propranolol, people have not used digoxin that much because of the risk of WPW syndrome.
What about an echocardiography? Is there a role of echocardiography in all these patients?
Ideally, echocardiography is indicated, but usually in a SVT, the structurally usually normal heart most of the time. Only occasionally you may have a structural heart disease in the form of Epstein anomaly, especially when there is a WPW syndrome.
Now we have had a lot of anxiety of the WPW and SVT, and people have managed all these things, and we are happy. The parents are very happy. Both the twins are doing well, all managed very well under care. But then we get a small message that the first twin who had been operated and who was ventilated was stable and doing all right, suddenly desaturates and saturation is coming down. And at that moment, unfortunately, Dr. Jayachandran happens to be visiting Dr. Shahnawaz, and Shahnawaz has gone out for a cup of coffee. So they ring Dr. Jayachandran up and ask him, suddenly this baby is our old patient, operated, sir, on a ventilator. What is happening? It's desaturating. Call for you, Jain. Okay. Any baby, especially who had a thoracotomy on ventilator, is suddenly deteriorating. We have to think about some emergency condition. And one condition we always need to rule out is tension pneumothorax. I'll say it should be a routine practice by all nurses, and all NICU should have a transilluminator with a code light. It should be a routine practice to look for pneumothorax on any baby with respiratory distress, especially preterm with distress or term with meconium or post-operative, to actively suspect for pneumothorax. Okay, if it's a tension pneumothorax which is causing hemodynamically affecting the baby, then without waiting for an X-ray, we have to do needle aspiration in the second intercostal space wherever site is affected. In this baby, I assume if it was the same baby who had a surgery for tracheoesophageal fistula, I assume this baby will have some chest drain. So we have to make sure that chest drain is working. So once the drain is blocked, do you want to touch it or put another one in?
Okay, if the drain is not working after needle aspiration and doing an X-ray, then we have to consider chest drain needle. And it's a good practical skill any neonatal should have, especially with using the Vigon chest drain needle, which is not technically that difficult compared to the traditional chest drain put by surgeons. So Vigon needle is available everywhere, even though it's 1,000 rupees expense, but it's very easy to use. But the message I want to convey with pneumothorax is all pneumothorax does not need drainage. If it's only tension, we have to do as an emergency procedure. Minor pneumothorax, we can even wait and watch for 2-3 days. It may spontaneously resolve. And also, there is no point in giving too much oxygen or too much ventilation for a baby with the pneumothorax. Whatever saturation is expected for the gestation, we can give. So high index of suspicion, tension pneumothorax, put needle, do X-ray, then go for chest drain with the Vigon needle.
I got two queries in what you said. You said about cold light. How reliable is cold light in term large babies?
If it's a significant pneumothorax, large pneumothorax, it will be picked up. Minor things we may have to again do X-ray.
What about localizing the cardiac apex when the patient comes?
That's an important clinical sign. That will be displaced to the other side of the pneumothorax. There may be decreased air entry on the same side. There may be a little bit hyperexpansion on the same side of pneumothorax. These are some clinical signs. And theoretically, I read that even the QRS complex in ECG will be of low voltage, but I haven't observed it.
Jacob, you want to add something?
I just wanted to kind of just clarify that if the baby is on the ventilator, there is a possibility that the pneumothorax will increase. So in that scenario, probably it is wise to put in a tube than wait. I mean, if it's otherwise normal baby not being ventilated, maybe it is okay with a small pneumothorax to wait. But the possibility
what is your comment about small pneumothorax waiting or not requiring oxygen? Not requiring oxygen at all, or advantage of oxygen?
They say that the oxygen helps the pneumothorax to settle a little faster. I don't know whether when it something that
the present guideline is not to over-oxygenate, just for pneumothorax only.
Exactly.
The word is very clear, not to over-oxygenate.
Yeah, as per the guideline of gestation of that baby, we can give oxygen.
Yeah, because alveolar oxygen elevation, because you can't compromise, especially the question of pneumothorax and preterm infants.
Preterm babies, yes.
You have a lot of air, but in a term infant, sometimes you may get away with giving more oxygen because of the simple fact that there is a simple physical diffusion between nitrogen and oxygen. And unless you have the ambient oxygen inside the alveolus more than the oxygen of air, you will not have the movement of the nitrogen also this side. Otherwise, same thing, the nitrogen will not diffuse out from the alveolar thing. What about the other shock situation that can occur in pneumothorax?
I think it's mainly because of the increased intrathoracic pressure, the decreased venous return and decreased cardiac.
Is it just enough to put a drain, or do you want to give any volume, or do you believe in any of those things, or just drain it and just wait?
The definitive treatment is always drain, but to keep the baby stable during that time, we can try a saline bolus. But the definitive treatment is always putting a chest drain.
Now, are you training your residents to put the drain yourself? How many are?
With the Vigon needle, I don't think it is that difficult.
Even with the other thing, it's not a big thing. It's not a big
cannula. I think the all neonatal should be comfortable in putting a chest drain, because the facility to have a surgeon or pediatric surgeon may not be available. Especially this type of scenario happen in the middle of the night. We'll be the only skilled person to save that baby's life.
I think Jacob, you are putting a standard drain. I think you are putting a standard drain like anybody else, isn't it? Just a typical, you can put a suction catheter in and doing the drain. Are you doing that, or are you using
We are using Vicon needle, sir.
What about Jacob? Everybody is using the Vicon needle?
That's a very easily put needle. But I have also used the other standard drain when there is no other.
We are using
available.
Regularly just a suction catheter. It's not a very difficult thing.
It's not very difficult. The other thing that I wanted to say is that if the baby has a tension pneumothorax and the person who's there is unable to put in a Vicon needle or a normal chest drain, even putting in a needle to decompress the chest, if the baby is is intubated, would be a wise thing to do, because of the intubation, the baby's lung would definitely get expanded, and on the ventilator, the baby will reasonably maintain, and you just need to keep periodically draining, or maybe just keep a needle to a side so that it doesn't injure the lung further.
Rojo, I didn't realize that you were scratching your nose or raising your hand.
No, sir, scratching the nose. Sorry.
So,
Be very careful with your hand.
I should not be rude because
you're observing very closely.
Yeah. No, so I had to be very careful. And tomorrow it's a sir, and I need to point to problem. So now we have a different scenario. A second baby is coming, very busy unit. A 34-week baby has been brought to your casualty. On exam, the heart rate is about 160, looks very pale, and maybe somewhere Rojo happens to be visiting Alappuzha for the conference, and Jayachandran is also going out. So Rojo, you are the only consultant available. They're giving you a call. 34-weeker, brought to casualty, heart rate 160, looking pale. Baby is all yours.
Thank you, sir, for the question. The first thing which we should ask yourself when you're dealing with a pale child is what age of life you're seeing the baby. So imagine if there's a day one baby who's looking pale, it could be either because of anemia or could be because of asphyxia. Now, if it is because of anemia, it can be because of three reasons. Either it could be because of blood loss, which could be an either acute or a chronic one, or it may be because of decreased RBC production, or it may be because of increased RBC destruction. So if you have a blood losses could be, say, an acute blood losses can occur in the scenarios related to the delivery. Say, if it's an abruption, it can be either from blood loss from the baby, or it may be related to the vasa previa or accidental insertion through the cord rupture or cord compression or cord prolapse, or a traumatic, or accidental rupture of the placenta. Or it may be a chronic conditions like a feto-maternal hemorrhage or a fetal hemorrhage, that is a twin transfusions, or very rarely feto-placental hemorrhages also. Now, if it is secondary to a decreased production, it could be something like a genetic disorders like a diamond blackfan or pure HCC, which slightly rarer ones, or congenital infections like IU infections or or secondary to parvovirus infections also. Now, if it is due to increased destruction in the initial days of life, it's mostly in the day one of life, it could be because of RH isoimmunizations. Now, if you're seeing after 24 hours of life, the reasons are reasonably the same, but the blood loss could be related to the time of delivery. Say it may be sometimes a large cephal or a large subgaleal bleed, which have caused a baby to become anemic. So,
can you have a feto-maternal?
Sorry, sir?
Feto-maternal?
I already mentioned that, sir. Okay. Fetal as well as feto-maternal transfusion, sir. And after 24 hours of life, it could be because of something related to the time of delivery, say somewhere last subgaleal bleed or cephalomatomas, or it can be sometimes an intraperitoneal bleed, which will happen because of a liver rupture or spleen rupture, or it may be because of something like a large intracranial bleeds, or you may be dealing with sepsis DIC where the child had a pulmonary hemorrhage. Or it could be because of increased restrictions. Whenever there is an increased restriction, it could be either immune or it could be either non-immune. Now, if it is immune, it can be either autoimmune or it can be isoimmune. Isoimmune can be again RH, ABO, as well as minor blood group incompatibilities. The non-immune mechanisms could be congenital as well as acquired.
Dr. Shanawaz, you want to comment on that? Because because see, I had a thing that we have this baby's heart rate is about 160. If it is a hemolytic element that is gradually happening, can you make out anything with the heart rate which is going up and or just take it easy about that? Because ultimately, it's the baby's come to casualty. You're going to tell them whether you're going to admit the baby immediately and manage, or you've got breathing time. Because that's what, how will you differentiate this? Any comments on that?
Sir, if the child is acutely, if you've seen the child and the child has the features of cardiovascular failure, that means it could be mostly an acute hemorrhage would have happened at the time of, acute hemorrhage. It's something like a chronic blood loss. That most of the times the child may be comfortable. When you see the baby, like the child may not have a features of cardiovascular compromise at the right when you see the baby actually.
Is there any other features you would like to look other than the heart rate?
So obviously, most important aspect of an approach should be the history. Like you need to have a proper antenatal history to look for the consanguinity of the parents, like in the blood group of both the parents. That is also very important. And medications which are given to the mother, any exanthematous fever for the mother, an antenatal scan details like as we mentioned earlier, polyhydramnios and oligohydramnios, which may tell you that the baby wasn't compromised. An MCA Doppler, which tells you that the anemia could be there or not, or bleeding in the pregnancy, which could indirectly tells you that which maybe the bleeding would have happened from the mother or from the baby. Now you'll also have to look into what exactly there was a mode of delivery. So sometimes like instrumental deliveries would cause a large amount of blood, especially you can have sometimes bleeding. I've seen large adrenal hemorrhages happening, a large liver hemorrhages or splenic hemorrhages secondary to difficult breech extractions. And family history also adds on to the approach, like a history of any bleeding in the family, jaundice in the family, gallstone surgeries. And most important is the previous history of any baby with a bleeding disorder. And obviously, another important aspect is the proper examination. Like if it's a well baby or a sick baby, or you're dealing with a baby who's having a jaundice. If you have a baby with anemia and jaundice, it could be either because of hemolysis or it could be because of some liver-related problems. Any other bleeding stigmata we are seeing like petechiae, purpuras, or any subgaleal bleeds, and evidences of hepatosplenomegaly, which may tell you that the baby might have either a hemolysis or maybe because of an intrauterine sepsis. And look for evidence of sepsis, which may tell you that the reason for anemia could be because of hemolysis.
I think PMC sir is very active because he's already answering many of the chat questions. So, sir, would you like to add something? I see he has replied many of the chat questions anyway on the chat.
You are muted, sir. You are
about a pale baby.
Sir. Please unmute, sir.
Unmute.
Adrenal hemorrhage can be one cause for severe
Rojo
as well as jaundice.
Now, does it happen immediately or does it happen after a little while?
It's in both ways. One by a severe adrenal hemorrhage presenting in real shock and pallor in the immediate newborn period, and the other one may be as prolonged jaundice. Then accidentally may pick up when you do the ultrasound.
Shahnawaz sir, you'd like to comment on your...
You have seen a lot of adrenal hemorrhages in the newborn during a scan, but I didn't see a patient with a stroke.
Have you seen cases that even after extensive investigation, we couldn't find a cause in baby with anemia?
You're talking about baby with anemia. See, anemia is
severe, like hemoglobin 5 at birth. We evaluated all these causes and we couldn't find an obvious reason. Is it anyone come across such situation?
Yeah, Jacob, you want to?
I just wanted to add two things. One is about the fact that we need to take a history of blood loss, especially clamp being loose and babies losing blood. This has happened with people. I mean, I've seen babies, having lost significant amount of blood with clamps having come loose. I mean, in the sense that as soon as the baby is handed over to the nurse or the pediatrician or the resident who's standing there, if they're not careful to make sure that they hold the clamp along with the baby, sometimes the clamp can come loose and baby is tied up in something and the baby actually exsanguinates. The other significant thing is about extra cranial bleed. Subgaleal bleeds can also be fairly significant. And we've had one baby who has had significant exsanguination from a subgaleal bleed. So that is something that I thought
I presume when you get something like that, you must immediately start looking for some coagulopathies also, because it's unexplained bleeding that goes on. You must keep that in the back of your...
But in a forceps delivery, in the background of a forceps delivery, sometimes I want, in that
Jacob, I think you of all the people should not say that because you won't get dinner at home.
Excuse me, sir.
Yeah.
Yeah, I think we have...
No, I got 10 minutes. I'm clipping a watch. You gave me time late. I'm looking at my watch. I got 5 more minutes. Your inaugural session went on quite long. Then, diaphragmatic. We have a situation where again, baby with severe respiratory distress. Jane, this is yours. Baby coming antenatally, no ultrasounds done, and you have a cardiac apex on the right side. severe distress.
Okay, sir. A term baby with respiratory distress, with cardiac placement on the other side, especially if it's worsening, the first step normally everybody will do do bag and mask. If that baby is worsening with bag and mask, we have to think about diaphragmatic hernia. Even though it should have picked up antenatally, we all used to get pleasant surprise of undiagnosed diaphragmatic hernia presenting with respiratory distress. The points I would like to highlight here is, if it is an antenatally diagnosed case, it is always better to electively intubate from the labor room. Also, if the baby is not improving, we don't know what is the case, if the baby is deteriorating on bag and mask, then also we should suspect, electively intubate and put a wide bore OG tube. The message I want to convey in diaphragmatic hernia is a big topic, but diaphragmatic hernia is a medical emergency, not a surgical emergency. That's the main thing. We have to stabilize the baby. We have to make sure that baby is not developing pulmonary hypertension, or if the baby is already on pulmonary hypertension, we have to treat it before.
Diaphragmatic hernia is a huge topic. Now, the crux of the picture you already told, at the time of delivery, people should have the habit of palpating for the cardiac apex.
Agree, sir.
And when you auscultate, I used to tell my students, till some pediatric person failed one of my students when they went for exam. I always say newborns start auscultating on the right side and not from the left side. Because if you auscultate on the left side, you'll always hear the heart sound, even if the heart is on the right. But if you start auscultating on the right side, if you say very good heart sound on the right side, and it's actually becoming lesser as you go to the left, you are in trouble.
Yes,
so
sir.
At Manipal, one of the students, when I auscultated like that, pediatrician said, "Who taught you this stupid method of evaluating?" So now I don't say that, but I always tell people, unofficially for exams, don't say it. But in practice, please feel it, because cardiac apex palpation may be difficult. But any cardiac apex, if on the right side, either you're dealing with pneumothorax or diaphragmatic hernia, both of them are equally dangerous. And because already Dr. Ravi, he's raising...
urgent X-ray is the main thing, sir. If you're suspecting this, do an urgent X-ray to confirm diagnosis.
Tube, intubate, urgent X-ray, shift.
OG tube, yeah. And one thing is, the previous tradition of routine paralysis is not at present. So we have to keep gentle ventilation, no need of over ventilation. Make sure it's medically stable, look for other congenital anomalies, stabilize, and then refer to surgery.
Doc, beautiful surgeon you have got, well operated, things are looking well. You're just planning to extubate the baby. Dr. Shanavas is doing his rounds. Suddenly the nurse says, pre-extubation endotracheal suction showed some blood. Dr. Shanavas, over to you.
Okay, sir. So when there is a blood-stained discharge or blood coming through endotracheal tube, always suspect two things. Number one, and the most important and most dangerous, is pulmonary hemorrhage. Second one, it could be due to a local suctioning like that, trauma due to suction. So how you should differentiate it is, there is always a respiratory decompensation in a case of pulmonary hemorrhage. So if it is there, you have to, there will be some, the ventilator setting may be more. So you need more people like that. So it is a clinical diagnosis. You can go for an X-ray. X-ray may not show much finding in mild to moderate cases. In case of massive pulmonary hemorrhage, you can see bilateral fluffy opacities. And the adjoint investigations are, you should go for a hemogram. So when there is a fall of hemogram, you can even still confirm that it is a pulmonary hemorrhage. And also, you should go for coagulation profile and sepsis screen, you should look for. So in a case of diaphragmatic hernia surgery, the babies are more prone to have pulmonary hypoxia. So that is one of the most common cause of pulmonary hemorrhage. So once pulmonary hemorrhage develops, you have to go for the A, B, C. A, you should look for a proper suctioning and remove the secretion. And B, you have to give more ventilator support in the form of, we may need more PEEP in the form of to a level of 6 to 8 centimeters of water. PEEP may be needed. C is, you should give a proper volume replacement with a saline, or you should may need blood transfusion. Then, so even though one of the reason for pulmonary hemorrhage in a preterm with HMD is surfactant therapy, you can offer them surfactant because whatever bleed that is that goes into the alveoli, that is the first thing that will happen. Alveolar hemorrhage, first thing happen. Subsequently, when there is increase in hemorrhage, it will go for interstitium. So all the surfactant get destroyed. So in that case, you can give surfactant therapy also.
Dr. Rojo, you want to comment on that?
So if it's if the lung is looking absolutely bad the compliance of the lung is bad, definitely surfactant might have a role, but you have to always bear in your mind that when giving a surfactant, you're actually reducing the pulmonary vascular resistance. Again, the pulmonary blood flow might increase, and this may open up the PDA again. It may always increase the pulmonary hemorrhage. That's a possibility, is always there. But the lung compliance is very bad. One can try a dose of surfactant.
What about volume? Volume being given in pulmonary hemorrhage?
Volume also depends upon what exactly the cause of pulmonary. So this hemodynamically in PDA is there. Giving volume might cause more problems to the heart. It's just like maintaining a normal circulatory status. But if the child is in shock, maybe you may have to give a inotropic volume support as well as an inotropic support depending upon the shock, or you may require sometimes, as Sir mentioned, coagulation factors. Sometimes you may need an FFP. The child is dealing with the sepsis and a DIC. You may require FFP as well as a good dose of vitamin K, because vitamin K is one important lifesaver in this scenarios.
I always comment, thank you, that pulmonary hemorrhage is very easy to talk across a table. But when you're having it, the only way to salvage a pulmonary hemorrhage, the neonatologist has to stand near the baby. You cannot give orders and go away because strategies change. In my practice, I do not give volume. In fact, I'm afraid to give blood products because I don't want the platelets to again come down further, because there would be thrombocytopenia. Anything that I give will dilute it. And first, till I get the blood controlled, I personally don't give any volume, no hemodynamic support. I don't even give FFP because I don't want a further consumption coagulopathy. The idea is to stop that bleed, which is a purely mechanical thing on the ventilator. And once I'm able to control that, only then we start addressing the next issue. And that few hours is a real nightmare standing there. And babies do get salvaged. But it is like, each person, you can cut the cloth whichever way you feel it. Ultimately, the babies have to live. I don't know whether any more questions are there in the chat box. Except
a question, sir. Adrenaline nebulization, is it useful in pulmonary hemorrhage?
Intratracheal adrenaline might be useful, sir. Intratracheal adrenaline might be useful in pulmonary hemorrhage.
We have not used anything. And in our practice, we don't give any of these things. It's pure ventilation, ventilation, and ventilation. And it's a really terrible thing to ventilate because you have bleeding, you have the coming down. And one thing I tell my people is don't go around doing suction, because there is no way you can suck out and take that blood out of the trachea. The moment you take out the pressure, it's going to bleed more. So you keep the ventilation up, go ahead, push it down, and gradually over some time it comes off. But then it's something which one has to be seen to believe how the blood actually comes down. As far as possible, there are no easy ways out in pulmonary hemorrhage. And that's why they like you say, the person who has to hit the winning shot has to be the best player. So Dr. Shahnawaz was asked to finish off the shot on pulmonary hemorrhage, because all queries can be asked to him and he'll probably tell us what all we'll lose out on that. Any queries to Dr. Shahnawaz? It's coming up in the chat box. Anything else is there? Yes, optimal PEEP and early HFOV. That is a big thing. Please, HFOV is not the answer for everything. For heaven's sake, HFOV, if there is any resistance to the tube, HFOV is a very poorly done style of ventilation. Everybody does desperately many things. And I always feel if you cannot control a pulmonary hemorrhage with a conventional ventilation, very few are able to control HFOV. But then, like we do many things and babies do survive despite us. Many of us do many things and babies survive. And that is why newborns are the toughest creatures on this world, because they can tolerate all that we do and they still survive. And then we claim credit for it. God has created a wonderful creature there. If there are, yes, Rojo?
There only one thing is like in this case of pulmonary hemorrhage, most important thing is we have to avoid the peepophobia. They should be going up on the PEEP. That is the most important line of management in the pulmonary hemorrhage.
So that's fine. And I think we have to keep the organizers happy. I should thank the organizers for giving me an opportunity to moderate this session, the inaugural session. And I'll leave it to all my panelists to make a final comment till we wind off, starting with Dr. Shahnawaz, Dr. Jacob, Dr. Jayachandran, Dr. Rojo, and then we can bid goodbye to the panel. Dr. Shahnawaz, please.
Regarding SVT, it is one of the most common cardiac emergencies that routine pediatrician and neonatologist should manage before it convert into sinus rhythm. Then only you can go for a cardiologist's opinion. So that is my comment on that one. And pulmonary hemorrhage is, as sir said, it is a very dreadful condition where most of the neonatologists nightmare. Thank you, sir.
Dr. Jacob.
Just need to say that as pediatricians or neonatologists, we somehow tend to ignore the surgical conditions in babies. And this is something that we need to never forget, that some of these possibilities need to be kept. A pneumothorax is something that we come across fairly often. A diaphragmatic is an occasional Foxer. The tracheoesophageal fistula can also be a reasonable Foxer at times. We've discussed some bit of it. So I think another thing that I just wanted to add is that there are times when babies will crash at the time of delivery, and we've had situations where they turned out to be diaphragmatic hernias. So it is always wise to do an X-ray at the earliest. Even if the baby dies on your hand, at least you have evidence of a diaphragmatic hernia to show. I mean, we've had a patient come from outside, came very sick, almost dying, but when we got an X-ray done, the baby had a diaphragmatic hernia. The baby was lost, but unfortunately, the parents otherwise wouldn't have been able to be told that there is a problem like a diaphragmatic hernia. It was undetected, and most of the times it is antenatally undetected.
My message is train your nurses and frontline workers to pick up the danger signs in newborns. And in real emergency, you attend it and stay there till the baby is stable. Thank you.
Sir, my message is like, if you have as I mentioned, the pale baby, always also look for any features of shock. Obviously, that is also could be a reason for the shock. My mentor, Dr. Vishnu Bhatt, used to say that it's my message to all the juniors who has been, I'm not sure, not to the seniors, unless you know normal, you don't know what is abnormal. So you always have to be at the bedside of the patient rather than the bedside of the ward. So that should be this thing. You should keep on feeling the pulse, keep on feeling the heart rate, and then knows a normal, then only you will know what is abnormal. Then only you can pick up a sick baby. Otherwise, you may end up in losing a sick baby. Thank you, sir.
Thank you, my panelists. It's been wonderful to have and chit chat with all of you here. I'm sorry if we could not address each and every question and allow it because of limitation of time. And if there have been any comments that I made which did not make you very comfortable, I apologize for it. And thank you, Dr. Ravi, for the very kind introduction. Like somebody asked me, I want your CV. I said, who's introducing that to CV to Ravi, who knows me for I don't know how many years. I'm glad you restricted the introduction to only the good parts. Thank you very much.
Thank you very much.
Thank you. Thank you. Thank you all.
Entire team.
Thanks for the organization.
It was a great learning experience. Okay.
Thank you.
Thank you. Thank you, sir. Thank you, sir.
Now, coming to the next session, Golden Hour Management in Preterm, the Need of the Hour, Dr. Somashekar Nimbalkar. He is Professor and Head Department of Neonatology. Param Sukh Swami Medical College, Karam Sad, Gujarat, Associated Dean, Research Services, Baikaka University, Karam Sad. He is a National Coordinator, IAP NNF NRP Program 2020-2021, Honorary Secretary, KMC Foundation of India, Executive Member, IAP Medical Education Chapter. Yes, lot of national and international publications to his credit. And he had been the President, National Neonatology Forum, Gujarat State Chapter 2015-2016. And many more accolades to his credit. I invite Professor Somashekar Nimbalkar to enlighten us on this very important topic. Over to you, sir.
Thank you, Dr. Ravi, for the kind introduction. And as I saw sir talking about time, so I will also keep time because I have 15 minutes and I will definitely finish it in 15 minutes. I'd like to thank the organizers, Dr. Manoj, Dr. Joseph, for inviting me to give this talk. Actually, a talk on Golden Hour Management of the preterm requires at least 1 hour. And since it's 15 minutes, I don't think I'll be able to do justice to the entire topic as per se. But the title says need of the hour. So It could mean two things. Is why do we need golden hour management is one way to look at it. And we should be talking about why we should be doing golden hour management. And second, what is generally anticipated and what generally is felt is what the talk was is what is the golden hour management. So I'll do a little bit of both, and so we'll try and see how we can go about the golden hour management. This is a slide from Lancet Global that published in 2009. The figure on the left-hand side is published somewhere in 2015, 2016, and it shows you with the various areas of maturity. Even today we consider a 37 completed weeks baby as mature, we do all know that there is a little bit called as early term and moderate term and term babies. So any babies who is between 38 and 39 weeks of gestation would be okay, but any babies before that, there are still problems even in babies who are early term babies. So there are different definitions for term and preterm which exist even today. But for a large part of the presentation, we will consider that any baby which is less than 37 weeks as preterm babies. Now, if you look at how many preterm babies are occurring across the birth, the estimated global preterm birth rate is just about 10.6% of all babies are premature babies. And they contribute to around 35% of deaths among the newborn babies, and 16% of all deaths as far as less than 5 years of baby. So preterm babies contribute to a lot of deaths, and so that is something which we should be considering. Of the 140 odd million births which are there, around 15 million births are preterm. So it's a large number of babies that we look after, and we need to look at. So this is across the world. But if you look at Asian and sub-Saharan African countries, they contribute to almost 81% of the global preterm birth cohort. In other words, Asia and Africa basically are the ones where preterm babies are being born. And if you want to guess as to how much US contributes to preterm births of the global population, it is just 2.4%. Now, why is that important? Because much of the research or discussions around preterm birth comes from that particular country, while in our countries and African countries, there is barely any research that is done on preterm birth. So this is a global map of preterm births, and the darker ones show the number of preterm births. So you can, as you can see from the map, India and China contribute to a large number of preterm births, with a little bit one particular country in Africa having almost the similar percentage number of births. So you can see across the world we have more preterm births. The color is actually purple in the map because that is how we kind of designate preterm births, especially when we celebrate Prematurity Day in November in the coming month from next week onwards. So this is the global estimated number of preterm births. So these are the top 10 countries, like the top 10 songs that we have in Bollywood or Hollywood, and so these are the top 10 countries of premature births. So India stands at the top, and if you look at the global percentage of preterm births that India contributes to is almost 25%. So 25% of all the preterms across the world are born in India, and that is the reason why we should be more looking after what is happening to those preterm babies that are born in our country. China, though equally populated as far as India is concerned, this contributes to around 7.8%, which means their antenatal management or infection management, etc., or the status of their mothers is much better than the status of our mothers, because of which we have more premature births, though both India and China have almost similar adult populations. For comparison, the seventh country on the list, USA, is just about 2.6%. So almost 10 times lesser than what we have. So these are the top 10 countries with premature births, and again, this is estimated numbers published in Lancet Global Health in 2019. We discussed as to what is the scope of prematurity, or what is the variation of prematurity. Is less than 28 weeks, 28 to 32 weeks, and 30 to 37 weeks. Now, most of the literature or the discussions that happen, and when we talk about LISA and Ensure, etc., we're usually discussing babies less than 28 weeks. And they contribute just to 4% of all the premature babies, while the majority of the prematures are actually in the age group between 32 to 37. Many of them actually may not even get admitted in the NICU because their weights are around 2 kg, 2.1 kg, and they may look bigger, and we may not, though they will be preterm, we may think that they're okay and they are often in the postnatal ward. It's only when they develop jaundice or they develop hypoglycemia on day 2 or day 3 are we worried about them. So the point I want to make here is, while we might look at the technical part of golden hour management of preterm, we should understand that most of the technical part of that we read in books or in journals is referring to babies less than 28 weeks, while the majority of the preterms that we are looking at or we need to manage are actually the 32 to 37 weeks, or often called as late preterms. This is how often they are described, and they are a huge number. And since India contributes to almost 25% of the global preterm premature births, we have to understand that 85% of 25%, so almost 22 to 23%, the babies born across in India would be almost about late preterm births which are there. Now, the concept of golden hour, why is it that it initially started off in trauma and other places, but it was introduced by Reynolds in 2009 in neonatology, where they highlighted the importance of neonatal care in the first 60 minutes of life. Now, this is mainly a journal which is used by nurses and neonatologists, and so this was introduced there first. And in 2014, Dr. Myra Bishkov, one of the important members of neonatal resuscitation ILCOR committee, wrote an article which said that it's a philosophical approach that looks at communication and collaboration using evidence-based protocols and procedures that standardize as many elements as possible for the delivery and initial management of a very preterm birth. In many ways, it is just not the evidence of the therapies that are being used, but we're looking at how to ensure that whatever is evidence-based, and because it is also time-based, because we have set a time limit of about 60 minutes or so, we have to be able to finish whatever we want to do within those 60 minutes. And if you want to do something within a specified time, like you want to do a conference within 4 hours and not overstep that time, we have to ensure that everyone sticks to those limits, everyone knows their roles and carries out those roles perfectly. So in a similar way, it has a lot of evidence. When you want to actually practice it, you actually require a lot of communication and collaboration between various people within the NICU, with the obstetrician and many other team members that look at neonatal care. So these are the overall basic principles of golden hour management, and if you look at each of this, we could spend around 10 to 15 minutes on each of them. But the most essential one is team approach, and this keeps up coming everywhere nowadays in various areas, whether you're doing quality improvement, whether you're doing neonatal resuscitation, or whether you're managing babies in the NICU. So team approach is absolutely essential, and everyone needs to be on the same page, and everyone needs to know what is happening and understand their roles and responsibilities. Preventing hypothermia is one of the most important parts, and we know that in the delivery room also, when a preterm baby is being delivered, we have to ensure that the delivery room temperature needs to be between 26 to 28 degrees centigrade, or some would say 25 degrees centigrade. The delivery room temperature is actually directly proportional to the if it is lower, then it is more likelihood that the baby, when it gets admitted to the NICU, is going to be hypothermic. And we know that hypothermia is an independent predictor for neonatal mortality. And every degree reduction in neonatal temperature increases the chances of mortality exponentially. So preventing hypothermia is important. And there are the strategies where we are using the food grade plastic bag, where we can keep the baby inside and ensure that the baby does not lose water and hence maintains temperature. We have to have around, initially there was this thing that babies less than 28 weeks need to be in the plastic bag, but the current guidelines suggest that babies less than 32 weeks can also go within those plastic bags and temperature can be maintained. Very important to know that we don't dry the babies when we keep the babies in the plastic bags. Thermal mattresses are often mentioned, but we don't have them available in our areas, and plastic bag is one of the best things that we can do. The head needs to be covered with a woolen hat, and that's something which also is easily done and should be done. Now, with delaying the clamping of the cord becoming more and more prominent, almost everyone knows that we need to delay the cord clamping by almost 1 minute or so, and this also remains true for preterm babies. There were some things that were there initially in the preterm baby management, golden hour management, which are no longer considered. So some of the earlier authors who wrote on preterm golden hour also mentioned sustained inflation and also mentioned cord milking, which are no longer to be done. So if you find them in articles, they're not recent, they're outdated. So just a caution to those people who might think that sustained inflation and cord milking are something which is good, and this should be avoided in extremely preterm babies. Again, effective and gentle resuscitation for preterm babies, handling them, because rough handling can lead to issues, and that's very important. The transport and stabilization to the NICU. So we have not discussed oxygen yet, but that's something we need to understand. When you are delivering babies in the NICU, when you are managing babies in the delivery room, if the baby is less than 28 weeks, then you could start with around 0.3 FiO2. But if it is more than 28 weeks to around 32 weeks or so, you could even use room air to FiO2. So this keeps on changing, and as you will see, the evidence for each of these therapies is being researched more and more, and many of these things keep on changing. So you need to be comfortable as to what we need to be doing. The respiratory therapy, we can start delivery room CPAP, and that I will not go into detail because it's a lecture by itself, but you can start CPAP, especially for babies who are breathing spontaneously, and that's something which we should need to do. And of course, communication of the family. This is a image from an article published in this year's, I think, February in 2021 by Daniel De Luca, and this shows the protocol of a French hospital, Paris-Saclay Hospital, where you can see M0 start, and they're starting CPAP from a baby who's born preterm, and then verify pressure transitions, apply pulse oximeter on the right hand, insert umbilical venous catheter by 30 minutes, start parenteral nutrition and proteins, etc. by around 32, between 35 to 45 minutes, transcutaneous blood sensors, and by M60 you should have finished all this, and it says a 10-minute tolerance, then you can get late by maximum 10 minutes or not more than that. And this, in this article, he's actually talking about how using lung ultrasound you can decide whether to use surfactant or not. So the point of the images, we need to have such kind of images to guide the unit as to what needs to be done. This is another one from the US. This is one particular single picture which I'll be showing across 3 slides. But it tells you that if you want to do a golden hour management approach in your hospital, you need to have it printed out, and you need to have it written clearly as to who's going to do what. So if you can look here, when you want to prepare, it says who needs to prepare, what is to be done, who needs to come. If you're using NeoPuff, which is the TP resuscitator, what pressures you need to keep. And if depending upon what week gestation it is, what you will do. In infants, you'll keep the baby intubated and keep the baby intubated, and so on and so forth. CPAP, you start with 6 centimeters of water pressure and cover the baby with plastic wrap and monitor vitals, place distal peripheral IV line, and so many things. So then transfer to the NICU, admitting the head in charge of that unit admits the baby, leader places order, and so on and so forth. And once you transfer the baby to the NICU, so it is like everything is written as to what needs to be done by at what place, at what time, and by whom. Okay, and if you see on the right hand side, there is QI data collection. This is being done continuously. Obtain UAC, UVC access, obtain labs, and antibiotics if required, and so on and so forth. The point of this picture that I have shown is that if you want to do it in your unit, you have to have it written down and put it out very clearly. This is from the 2019 update for surfactant use or management of respiratory distress syndrome, which has a lot of good points for this also. It's a very crowded slide and it's an image. You can find it from the net. But the points that I want to make is this has kept on changing, and we need to keep on looking at what needs to change and what we need to do. So definitely something which is also said that we need to start early in these babies. Since I'm at just 2 minutes remaining or 1 minute remaining, I'll skip and just go to saying that golden hour management has been changing even in the last 10-15 years as more and more new evidence keeps appearing, and very important to keep updated with the literature and have your own policy and utilize it in your unit. And you need to educate everyone in the unit as to how to go about doing it. And team training and communication is very important. While I will stop my presentation here, I will just show you a Word document as to how you need to go about doing it. So this is a 17-page document which tells how to go about doing the golden hour management for a baby. The point I want to stress is that this is, you need to have such a detailed document if you want to ensure that you're doing golden hour management in a unit. And I think with that, I will stop my presentation. Thank you very much.
Thank you. Thank you very much, sir, for the detailed insight into a very important issue. It was a great learning experience from your vast experience, sir. We are really grateful to you.
There are no questions, and maybe thank you very much. And I think proceed to the next one. I think it was within time. Thanks a lot. Okay. Bye.
Thank you very much, sir.
പല മീറ്റിംഗ് തിരിച്ചു വിളിക്കാം.
Good evening to all. So we are moving to the second session of our CME. I hereby introduce the chairpersons, Dr. C. Jayakumar sir and Dr. Nandakumar sir. Dr. C. Jayakumar is the head of the Department of Pediatrics, Amrita Institute of Medical Sciences, Kochi. He is former HOD of Government TDMCH, Alappuzha, and former IAP and NNF State President. Dr. U. Nandakumar is a national EB member, Central IAP 2022, senior consultant at Astor Mills, Kannur. I humbly request the chairpersons to introduce the speakers and thereby chair the sessions. Over to you, sirs. Thank you.
Hi. Good evening, all. Our respected President of NNF Kerala, Dr. A.V., Secretary Dr. Nilbi, the organizing chairperson, Dr. Shanavas, organizing secretary, Dr. Anandan, and my lifetime friend and NNF President of Alappuzha, Dr. Ojos. At the outset, I would like to thank the organizers, especially GTDMC and AAP and NNF Kerala for allowing me to be the chair of the very important session. You had a wonderful talk on the emergencies and also the golden hour by Dr. Somashekar. Now another important clinical problem that can have long-standing sequelae, that is hypothyroidism. To talk about this, you have an eminent speaker, Dr. Vijay Kumar. He's going to be the president-elect of IAP Kerala, and he's a professor and head of the Department of Pediatrics, Government Medical College, Manjeri. And then he's in charge of the endocrinology clinic of Government Medical College, Kozhikode. He has a very good teacher, wonderful clinician, and he has done a lot of work in the field of endocrinology and had a lot of papers. With this introduction, I would like to introduce Dr. M. Vijay Kumar to deliver his talk on congenital hypothyroidism. The sooner, the safer. Catch them young and treat them at the earliest. Dr. Vijay Kumar, please.
Thank you, sir. I think I am audible.
Yes, you are audible.
Yeah, my video is not because of some net connection. I'll just close the video and start.
Oh, sorry.
So, respected Jayakumar sir and Dr. Nandan and all the organizers of this wonderful CME, I express my sincere gratitude for giving me a chance to deal with a very important problem in the neonatology, that is diagnosing and managing congenital hypothyroidism at the earliest. So this is the first clinical scenario. This is a 2-year-old boy with delayed development, constipation and coarse facial features. It was diagnosed by one of the resident in our IMCH OPD. But you are late. In congenital hypothyroidism, treatment should be started before 14 days of life to get a near normal intelligence. So this should be diagnosed. This diagnosis by clinical examination should be the diagnosis of the past. However good you are clinically, you can diagnose only 1% of congenital hypothyroidism in the newborn period. The congenital hypothyroidism is the most common cause of preventable mental retardation in children. And after the advent of newborn screening, the incidence is as high as 1 in 2,000. Years back, it used to say that incidence is 1 in 4,000. Now the incidence is increasing. And many studies from India and even in Kerala, the incidence is as high as 1 in 1,000. And only 1% of congenital hypothyroidism can be diagnosed clinically in the newborn period. Hence, universal newborn screening should be practiced in all hospitals where a delivery is being conducted. So, newborn screening is the birthright of every child. The case scenario, I am going to another baby who was diagnosed by the newborn screening program. A term boy with birth weight 3 kg was undergone newborn screening at 48 hours. Screen TSH was 90 units and he was recalled and confirmatory venous thyroid profile was done which showed a T4, very low T4, 5 microgram per deciliter and TSH 120 milli international unit per liter. So when will you do thyroid screening? Screening can be done at the time of birth, that is by doing a cord blood. So you can see that this is at birth and within few hours the TSH rises and it will reach very high value, that is called as TSH surge. You can see that TSH is increasing and it is rising to as high as 70 units and gradually it will come down and by 48 hours it will become the high normal range. In preterm, you can see the hike in TSH is not as good as in a term baby, but it also increases and it will come down. So this is thought to be due to the sudden transition to a hypothermic from the environment outside the womb and because of the stress of the delivery. And you can see that along with TSH, T4 is also having elevation and by 24 hours, you can see that T4 also is very high and it will come down, it will be less, it will reach normal by the end of 7 or 8 days. So you can do the thyroid screening at the time of birth or at or after 48 hours if not done at birth. So this is called as TSH is elevating and by 2 days TSH has come to a high normal state. And what are the advantages and disadvantages of cord blood screening versus postnatal screening? Cord blood screening is painless and it is not affected by neonatal surge. It can be done in all neonates because if you have a written policy in your labor room, all neonates can be screened and report will be ready by the time of discharge and you can start treatment even before discharge. And the main disadvantage is if you are clubbing with other newborn screening, you cannot screen by cord blood because other metabolic conditions like phenylketonuria or galactosemia or biotinidase deficiency should get accumulated after consuming breast milk. So we have to wait at least for 48 hours. And another endocrine disease like congenital adrenal hyperplasia, the levels will be very high. 17-hydroxyprogesterone level will be very high in the just immediately after birth, and its levels will come down after 48 hours. That is also because of the stress of the delivery. So you have to wait for 48 hours. And for cord blood screening, round the clock personnel should be there. Every person, every nursing staff should know about the newborn screening. They have to send the blood immediately. The main disadvantage of postnatal screening after 48 hours is that is a painful. So we are giving vitamin K, we are giving so many injections. So along with that, you should give one more prick. And neonatal surge may affect the result, especially if you are doing within 48 hours. And it may be missed in children who get discharged early. Some of the children may get discharged even before 48 hours, so you will be missing. And report may be delayed and we have to recall them for repeat test. But main advantage is other metabolic disease can be tested. And sample collection can be done during a particular time in the morning hours. We can fix a particular time and you can collect the samples. Next thing is whether we should do a TSH assay or T4 assay or a combined assay. The world over, most of the laboratories, most of the hospitals in the West, they are doing primary TSH assay. because that is more sensitive and cost effective. But main problem is that will miss the babies with delayed elevation of TSH. In premature child, maybe the TSH may be normal and gradually it will increase. And sick babies in the NICU, the TSH level will be falsely normal, and after few days it will get elevated. That is called as delayed elevation. And altogether you will miss central hypothyroidism because TSH will be low in central hypothyroidism. Another group, they are performing primary T4 assay. Here central hypothyroidism could be picked up. But problem is it will miss neonate with a compensated hypothyroidism. Compensated hypothyroidism means T4 level will be normal and TSH will be elevated. Such children will be missed. That is much more common than central hypothyroidism. And values will be low in preterm, sick newborns and thyroid binding globulin deficiency. Hence, there will be a high recall rate. And as a whole, many are doing TSH assay. A combined assay can be done, but that is not cost effective. And collection of blood by heel prick, it is wiped and just a prick by a lancet, you will get a small blood coming out, and you can take 4 or 5 wells in the filter paper. You can collect the sample. If you are doing at least 3 or more neonatal screening, you can do it, and the remaining you can even keep in the lab for years together. What are the cutoff? All over the world, now they are using TSH value 20 milli-international units, serum units. That is recommended as the cutoff for recall for both cord blood and postnatal sample after 48 hours of age. If you are using a whole blood unit, it has to be converted into serum unit by multiplying with 2.2. But many of the labs are giving the report in serum units. If you are giving some labs, some in countries, they have started using 15 as a cutoff, but false positive rates. So many will be mild surge, or that is called as transient hypothyroidism, will be diagnosed, and the treatment, you have to treat more children with transient hypothyroidism. In a study, if you are using a 20 units as the cutoff, even in them, at least 30% were transient hypothyroidism. If you are decreasing the TSH cutoff to 15, the percentage of transient hypothyroidism is as high as 70 or 80%. So if the screening value is positive, the child is recalled and a confirmatory venous sample for both T4 and TSH. Either you can use T4 or FT4. The main advantage of FT4 is this thyroid binding globulin deficiency can be picked up. So the interpretation is, before 14 days, if the venous TSH is about 20, and after 2 weeks, if it is about 10, you can diagnose as that child is having elevated TSH. What is low T4 or low free T4? If the serum T4 is less than 10 microgram per deciliter or less than 128 nanomole per liter, you can call that child is having a low T4. If you are using free T4, if the value is less than 1.17 nanogram per deciliter or less than 15 picomole per liter, you can call that child is having low free T4. What is meant by very low T4 and very low free T4? If the serum T4 is less than 8 microgram per deciliter or less than 100 nanomole per liter, that is a very low T4. If FT4 value is less than 1.1 nanogram per deciliter or less than 12 picomole per liter, that is called as very low free T4. So this is the algorithm for screening and detection of congenital hypothyroidism. So you can do a heel prick or cord blood. That is the first screen. If TSH is above 20, confirmatory venous sample for TSH and T4 should be done. If it is less than 20, it should be considered as normal. Suppose in the confirmatory venous sample, if there is low T4 or free T4 and high TSH, start treatment. If it is very low T4 or T4, irrespective of TSH also, you can start treatment, but there is a chance that this child may be having a transient hypothyroidism. If there is a normal T4 or FT4 and high TSH, start treatment if TSH is about 10 even after 3 weeks. There is also a chance that you are dealing with a case of transient hypothyroidism. If there is normal T4 or FT4 and normal TSH, there is no need to treat the child. If the screening value is very high, more than 80, thyroxine can be started while awaiting the confirmatory results. But in our area, we will get confirmatory results within hours. So there is no need to start before the confirmatory results. Then what will you do after starting treatment? Any other investigation we should require? Thyroid imaging should be done to identify pathology. Imaging modality may be either ultrasound or thyroid scintigraphy or both together. Both are complementary to each other in reaching the etiological diagnosis. Thyroid scan can be done even after initiating treatment. So if you are doing an ultrasound, that can be done at any time. But scintigraphy can be done as long as TSH remains high. At least 7 days after initiating treatment, you can do a scintigraphy. So this is the normal gland in the thyroid radioisotope study. And this is a case of agenesis of thyroid. And this is a case of an ectopic thyroid. So usually ectopic thyroid is much more common than the complete agenesis of thyroid. That is there even in our study, the agenesis was much more common than this ectopic was much more common than agenesis of the thyroid gland. But always see that imaging should never be a reason to delay the initiation of treatment. If somehow the imaging is get delayed, you have to start treatment. Our main aim is to treat the child as early as possible. Don't wait for the imaging. If imaging could not be done at the time of diagnosis, especially the radioisotope study, it can be done at 3 years after stopping treatment for 4 weeks. Then how we plan treatment? So if you start treatment, you have to start levothyroxine at a little bit higher dose compared to the older child. So the treatment dose is 10 to 15 microgram per kg per day. If the TSH value is high, you have to start with a higher dose. And if the TSH value is low, you have to start with a lower dose. So, and we have to, during each visit, you have to do both T4 and TSH. Don't do only TSH. And we have to titrate the dose in such a way that the TSH should be in the lower limit of the normal and T4 should be in the higher limit of the upper limit of the normal. And you can plan the first visit at 2 weeks after initiation of treatment. And remember that the TSH will be even slightly elevated if you see the child at 2 weeks. So don't adjust the dose at 2 weeks. You can wait for 1 month. Second visit should be at 1 month. Then usually TSH and T4 should be almost normal. And every 2 months up to 6 months, you have to follow up the child. And then every 3 months up to 3 years, you can follow up. And after 3 years, if everything is doing fine, you can follow up once in 6 months only. But if you're planning, if you are just changing the dose, then better you can ask them to come back after 1 month to see if it is normal. And monitor T4 or FT4 and TSH. Do drug titration and see if there is some abnormality. Suddenly there is abnormality. The TSH is a little bit high. Always see that compliance is good. Then if the compliance is good, then you can do the drug titration. And you have to assess the growth, linear growth, height, whether child is improving it. And you can also see the development and IQ later. And always use age-related cutoff. So this cutoff, it is there in Harriet Lane handbook, and the recent Indian Society of Pediatric and Adolescent Endocrinology guidelines also, we have given the age-related cutoff. Don't use the adult cutoff. Another thing is, what will you do at 3 years? Now there is a practice that every child, they will stop thyroxine and see whether the TSH value is increased. That is not needed actually. If initially itself, you have diagnosed that there is thyroid dysgenesis, either a complete agenesis or hemi-agenesis, or even in ectopic, they require lifelong treatment. So if the thyroid dysgenesis is diagnosed by scintigraphy, that child can be given treatment for lifelong. We cannot stop it. And assessment of permanence should be attempted only in a suspected case of transient hypothyroidism. So even in the beginning, you can diagnose transient hypothyroidism because TSH level may be slightly elevated or T4 may be slightly low. And the ultrasound scan, if you are doing an ultrasound scan, they will show a normal thyroid gland. So you may be dealing with a case of transient hypothyroidism, and the requirement of thyroxine for after months will be very low. If your requirement is 12.5 or 25, even at 3 years, then indirectly that will tells you that you are dealing with a case of transient hypothyroidism. But if the requirement is getting increased every visit, and you are treating with 50 or 100 microgram of thyroxine at 3 years, you are not dealing with a case of transient hypothyroidism, and you need not stop the treatment and see the response. So usually a transient hypothyroidism, the thyroid requirement at 3 years will be very low. This is another case scenario. A preterm baby with gestational age 32 weeks admitted for probable sepsis, and screening TSH was 18. That is just below the cutoff. What will you do? So in some high-risk neonates, preterm, SGA babies, sick babies, child is having sepsis, asphyxia, and he is admitted in NICU, twins, particularly monozygotic twins, there will be an attenuated TSH surge. So at the time of screening, the TSH surge may not be that much. So you will miss. And immaturity of the hypothalamo, pituitary and thyroid axis, especially in a sick babies, that is called a sick euthyroid syndrome, you will get a negative value. And if you use iodine as an antiseptic, and another thing is low levels of thyroid binding globulin. If your liver is not producing enough thyroid binding globulin, the value may be abnormal. So you may miss. So their TSH may not be as high as expected, and T4 may be low. So all high-risk newborn should have a second screening at 2 to 4 weeks of age. That is there in all consensus guidelines. If you are seeing a high-risk baby, you should have a second screening at 2 to 4 weeks or by the time the child improves. This is a case scenario. This is a term baby born by breech extraction, weight 2.5 kg at birth. On examination, he is having a microphallus with well-developed scrotal sacs and bilateral descended testes. Baby had an episode of hypoglycemic seizure on day 4 after birth. His screening result showed TSH is 4 and was not recalled. As part of the evaluation, thyroid function was again repeated, which showed TSH is low 1.2 and free T4 is also very low. So this child is having central hypothyroidism, low TSH and low FT4. So this child has got low TSH and low FT4. This is in favor of central hypothyroidism. This child is having features of pan-hypopituitarism. So MRI should be done to rule out structural anomalies. Other pituitary hormones should be measured like growth hormone, cortisol and gonadotropin. We have to replace with thyroxine, growth hormone and cortisol. Titrate the base. So what will how will you titrate the dose in central hypothyroidism? Because always TSH level will be very low. So you have to titrate based on the T4 or free T4 level because TSH will be always suppressed. And another case scenario, this is a 6-month-old female infant, second of the twin, normal initial screening, but child is having subsequently delayed milestone. You can see this child. This is a typical case of congenital hypothyroidism. So a normal initial screen doesn't rule out congenital hypothyroidism in all cases. So repeat thyroid profile if clinically suspected hypothyroidism at a later age. So the carry home message is newborn thyroid screening should be made universal. So all children we have to do thyroid screening. TSH based screening methods are more popular. Cord blood or dried blood sample after 48 hours of life can be taken. Cutoff of TSH is usually taken as 20. And repeat testing on venous blood, T4, both T4 plus TSH should be done if screening value is above 20. And initial dose of thyroxine is 10 to 15 microgram per kg per day. Trial of therapy at 3 years should be considered only if transient hypothyroidism is suspected. I have taken the reference from Indian Society of Pediatric and Adolescent Endocrinology Newborn Guidelines, Part 1 and Part 2, that is there in Indian Journal of Pediatrics. And another IAP recent advances in pediatrics, newborn screening for congenital hypothyroidism. Thank you for your patient listening. I hope I have not exceeded the time limits. Hello.
Hello, Jagma sir. Hello.
Hello.
Jagma.
Hello, can you hear my question? Hello.
Hello, I didn't hear the question.
Yeah, I will repeat the question. Should we repeat TSH after 2 weeks if 48 hours TSH is below 10 to 20? Second question is, after initiating treatment, which one should be given preference, FT4 or TSH? And third one is, what should be done if TSH is very low and normal FT4 even after titrating levothyroxine to the lowermost dose before 1 year of age? So there are 3 questions are there in the chat box.
I will answer to the first question. Should we repeat TSH after 2 weeks if 48 hours TSH is below 10 to 20? No need to repeat. Suppose if it's a term baby and there is no risk factors like prematurity and sick baby, you need not repeat. Suppose if the child's TSH is between 10 to 20, whatever chance he may be having, he may be having a transient hypothyroidism and treatment may not be needed. Suppose if the child is definitely having a congenital hypothyroidism like agenesis or ectopic, the TSH screening value will be very high. So if you are dealing with a moderate, because just below between 10 and 20, unless the child is sick or if it is not a preterm, you need not repeat. After initiating treatment, which one should be given preference, FT4 or TSH?
TSH.
But you cannot follow up a child only just based on TSH value. So always we have to do a combined TSH plus T4 you can do. FT4 or T4, that is your choice. All over India, the sensitivity of FT4 is not good compared to T4 because that is a relatively newer test. So sensitivity of T4 is better than FT4. But if the child is having thyroid binding globulin deficiency, then the FT4 may be better because that is a free T4. And doing follow-up, many are doing FT4 or some are doing T4. Some people are doing both FT4 and T4. But don't do T3 because we are doing just routine thyroid function T3, T4, TSH. T3 is not at all needed for diagnosing and management of congenital hypothyroidism.
Last question. Even after
what should be done if TSH is very low, below normal and normal FT4, even after titrating LT to the lowermost dose before 1 year of age?
Yes.
I didn't understand it because if TSH is
he has
very
given
low,
the lowest dosage. He has given the lowest dosage, but respect to that TSH is very low.
Yeah. So that indicates that one thing, he may be having a central hypothyroidism. We have to rule out other causes of we have to rule out other possibilities of central hypothyroidism clinically and investigation wise. If there is no central hypothyroidism, there is you may be dealing with a case of transient hypothyroidism. So usual dictum is that is gradually that dictum is changing. So far the dictum is, as per the consensus, you have to give a very small dose and keep the thyroid function in a normal state and continue up to 3 years because the brain development, maximum brain development is occurring till 3 years of age. Then after 3 years, you can take a risk and then stop and see. But nowadays, the consensus guidelines are changing. That is why if you are getting a very low TSH value and it will be higher T4 value with a very small dose of thyroxine, even less than 12.5, then that is almost a case of transient hypothyroidism. You can take the risk even at 1 year and see after 1 month whether the thyroid function testing TSH value is increasing after stopping the dose for 1 month. Nowadays their guidelines are getting changed, but as of now it is better to give a very low dose till 3 years and see the response. After 3 years, just stop and see the response.
Dr. Vijay Kumar sir, one more question from me. That means which fluid you mix this L-proxin tablet? Is it milk, breast milk, or
breast milk?
Clear water? Breast milk.
Yes, breast milk only. So breast milk doesn't because that doesn't affect the absorption of thyroxine. So you can use breast milk because anyway we are practicing
exclusive breastfeeding. Exclusive
breast milk policy, exclusive breast milk policy. So I think we can put it in breast milk and give it. No need to
One more question from me. That means in the third scenario, you said if the T4, FT4 or T4 is normal and then TST is slightly high, you have to start treatment. What do you mean by normal? It is above the median of this normal value or lowermost value of the T4.
T4 is the normal, means that is the even the uppermost.
There is a range. There is a range, always.
There is a range. So even if it is just above that cutoff, you can take it as normal.
Okay, and then you have to start treatment.
Yeah, but TSH should be about 10. That is that cutoff. Up to 2 weeks, about 20, and after 2 weeks, if it is about 10, you can start treatment.
Thanks, Dr. Vijaykumar, for your wonderful presentations. It was very clear, and you have cleared all the doubts of the audience. Now, the most important topic, the hot topic of the day is early childhood development, especially after Dr. Piyush Gupta has come out with the early childhood development program. You know, there's so many preterm babies are surviving, and it's our duty to give them the best care. So not only in the gross motor function, but fine motor, language, social, adaptive, vision, and hearing. So to talk about this, you have a wonderful speaker, Dr. Naveen Jain. Naveen Jain need no introduction to this audience. He is the senior most postgraduate in the sense that DM professor in the state of Kerala. So he knows very well, all the people, all the pediatricians and neonatologists know him very well. He's an international speaker. So he's the best person to talk about this very important program that is early childhood development. At what age you start? What are you going to offer to become the normal children of our country? Dr. Naveen Jain, please. Dr. Naveen Jain, can you hear me? Are you there?
Good evening. Actually, Naveen is traveling, so I will play his.
Probably I'll be able to be on a interrupted internet because I.
So recorded video will be there.
Okay, Dr. Naveen. Okay, recorded video. You may please that.
So on Naveen's behalf, I'll play the video, his talk.
Sorry.
Good evening, friends. I'm sure we all have done this experiment. In near the window, and we found consistently that the plant turns towards light. In fact, if we change the direction of the pot, the plant would again turn its direction, sometimes finding beautiful spirals being formed this way. So you can see that even the lowest form of creation in ontogeny has the ability to change the way it should grow, able to sense the right stimulus it requires, that in the case of a plant it is light, and seek and grow towards the light stimulus. So for all those friends who were looking for scientific evidence that giving the right stimulus at the right time can change the path of growth for the better, what we have called previously as neuroplasticity.
Oh, I got it, sir. Oh, okay, thank you, sir. Thank you.
In daily practice, we as pediatricians tell our parents to spend quality time with the child. Specialists, developmental pediatricians, neurologists would believe about autistic behaviors happening if the child does not get special stimulus from the parent at the right time and at the right age. It is called as joint attention, which is a very important part of learning, where there is a synchrony between the mother and the baby. And almost like in sci-fi movies, everything that the mother has learned, she is transferring to the baby. You can see in the image by joint learning. And even in the image on this side, you can see how learning happens. The mother looks at an object, she speaks about it, and even the child is learning, which means it is possible to modify a child, his brain, at a stage of young infancy and childhood to learn something, which means we must be aware that the formation, growth, synapses of neurons in a newborn, in a preterm, in a fetus is happening at much faster rate than in a child. This is a very simple experimental model. Mice are placed in cages where they have food to eat, a slide to play, something to smell, some activities to do. And this has been one of the most important experiments to prove learning through experiences. Mice who were born preterm were placed in 3 different types of cages. One is the standard condition, very similar to our NICUs, where we have mice but not much of good stimulus. A bad condition where the mice is placed alone with no family members visiting the mice. And an ideal condition where there are both family members as well as there are activities to do, things to play, and the right stimulus at the right time. And when these mice were later sacrificed and they were studied, the mice who were in an enriched condition had rich synapse formation. The neurons were connecting with each other. Important transfer of information was possible, whereas the mice who were in condition where there were lack of stimuli, there was no synapse formation. So it is the presence of the stimuli which causes or induces a synapse formation, like you saw in the plant, like you saw in the child who learns his language only if it is taught. So having a bad condition where your preterm babies spend time in the NICU for weeks together without the right stimuli from the parents is going to create babies with neurons which are like cell phones, which don't connect, which have no network. So if you want a baby to be having the right development in the form of synapses, then it is just not enough to give stimuli. It should be the right stimulus at the right time. And this can be given only by the baby's parents. They should come, touch, talk. The body smell of the mother should be offered to the baby. They should be having the right conversation with the baby. And this is so critical. Each part of these mice was stimulated appropriately. You can see the presence of right things to see than always the walls of the NICU. The baby should see the mother's faces. He should see some colors and lights for visual stimulation, for the visual cortex to grow. They should have some movements in the NICU, both passive and active, rather than just lying fixed in a bed.
Go park it. Then we don't have to leave it at them.
Act and respond. There should be somebody stimulating the baby to respond back, to develop a cognitive development. And here you can see once the baby starts doing normal things like he would have done, and he would develop his somatosensory pathways. Now coming to things we could be doing incorrectly, we all are very conscious who are looking after babies and putting cannulas or applying a nasal prong, and we keep checking every day whether there are injuries. We have scales for measuring nasal injury due to prongs. We have VIP score for measuring extravasation of cannulas. We are very conscious about these because these are injuries we can see. The injuries we are creating to a growing brain, which are due to a very noisy environment, a painful NICU stay, too much of bright lights, foul smelling hand rubs, all these we can't see. This is what was the past, but today by doing special imaging techniques like the diffusion imaging, fractional anisotropy, tractography, we are able to track each single of these that I showed you in the previous image and find out that the baby is having injuries due to bad stimuli or developing normally because of good stimuli that is given to the baby. So there are serious injuries we know now. We can see them to the developing brain by studying the microstructure. So we know that, or we have proved that preterm babies have brain changes that are happening very fast, and when the babies are in NICU, and these are associated with the experiences they have in the NICU. There could be deviations in development from normal if the baby experience is not similar to what it should have been in utero. It's also important to know about the critical timing of these stimuli. In this experiment, preterm mice were given a startling sound, a sharp sound, and they did like this. After some time, another sound was given, and again they started. When the third sound was given, the preterm mice didn't respond. This showed that they had learned about this experience. This is called habituation, and it is a proof of memory and learning. This was happening well on the first day and second day, but from third to seventh day, the mice did not show a good learning to the same stimulus, beyond which this learning experience returned again. This experiment demonstrated that each stimulus has a right timing to be presented, and by knowing what the fetal senses are and how they develop in time, we could plan which stimulus should be exposed to the preterm neonate in the NICU at the right time. So the timing of interventions are very, very critical. It is not enough to think that let the baby become better, survive and go home, and then we can start stimulating the baby. It may be just too late. Many of the learning opportunities, the right growth of synapses and directions of the fibers may have lost an opportunity and never to be repaired again. One experiment was that with mother's voice, and this experiment became popular or necessary because the previous experiences with comforting music in the NICU, like the Beethovens and the Mozarts, did not produce all the desired changes that they wanted to measure. Then people thought maybe the baby should be hearing what he was supposed to hear in utero. So the mother's heartbeat, the uterine souffle, the mother's breathing sounds were recorded and continuously played into the incubator by a device called Baby. I saw this device in Italy when we went for a DSC workshop, and that was going to cost something like 6 lakh rupees. In India, probably we had to improvise and have a more real and cost-effective solution like KMC, where we would continuously hear the mother's sound without the need of a device of this kind. Also that babies who heard the mothers speaking to them in adult language, that means babies, mothers and fathers talk to the baby, they had better adult language development at entry of school age. So what we have learned is clearly that the baby should be presented in NICU, even if it's a 27, 28, 30 weeker, 32 weeker, for the days that he spends in the NICU with mother's voice, and through KMC, the baby should hear the mother's heartbeat and the respiratory rate, uterine souffle, as long as possible, and noise should be avoided. There is clear physiological proof also that when noise increases, the baby's sleep is disturbed, baby cries longer, and the intracranial pressure is high. So what we have learned so far, that brain damages are happening in the NICU. We can now see it by sophisticated imaging techniques. Noise is surely damaging. Please try to reduce the noise in your unit. The alarm should be quietened. Maternal voice or adult language improves the language development, and interventions may start as early as 30 weeks because in fetal ontogeny, it is by this stage that the babies respond well to sound. Similar experiments were done with smell. We have all noticed that the babies sneeze and become irritated when we take a hand rub near the baby. So it was shown that the babies love the smell of colostrum, which is expected, of water, but vanilla or even the method used for material for removing, that includes hand rubs and alcohol-based rubs, cause irritation to the babies and is not a good thing to do. When the babies were presented with the smell of milk by either applying a drop to the mouth before feeding by tube feed, this is both colostrum mouth paint, and even continuing later, that every time a tube feed is to be offered, one drop is put into the mouth. The babies had good growth of their gut. They gained weight well. We all know that if we were in real physical conferences, when we start getting the smell of food in the next room, our hormonal production starts from the GIT. We get more hungry. And this would, the same thing would happen to the baby, that instead of giving all the milk only by a tube, where either the taste or the smell, if one drop of milk is applied to the mouth before an OG feed is given, then the time to full feed will be short. We are already doing this experiment in our NICU as well. Stimulation of the mouth is very important. There are protocols. One of them is called the preterm oral motor stimulation program, POMI, and these will ensure that baby can transit from OG feeding to oral feeding quickly. There are several protocols for passive movements for stimulation of the baby by touch and massage. And for them, for example, one of them says 5 minutes every day for 10 days on the neck, back. Another one says rhythmic movements 2 minutes and 2 minutes after feeding and before feeding. And many of them have shown benefit. You can see the massage being done here. They are all useful, and even from experiments from India, they have shown improved sleep time, better heart rates and lesser apneas, better weight gain in babies who had massage in the unit. The right position is important. The babies need to be brought into a flexed midline position, and swaddling them like they would be in utero improves the tone and reduces motor delay. The babies must be positioned alternately and not in the same position all the time. So we have learned today already that NICU experiences do improve the brain development. Babies need to be placed in the right position in the NICU. They have to have a massage and oral stimulation. They have to be presented with smell and taste of milk before they are given an orogastric feed, so that they would have better hormones and growth of the gut. This is one schedule of a unit showing how the lighting needs to be reduced during the evening and reduced to something as a minimum. And also, if the babies are normally requiring bright light for care, during the rest time it should be reduced to below 200 lux. And this is very critical to help them sleep. In our unit, we have integrated the development supportive care into intensive care. Otherwise, it becomes second importance and gets forgotten. On day one itself, the welcoming note includes not just intubating the baby, doing blood sugars. It introduces to the parents the need for this program called early parent participation, and that they have a role from first day. The mothers are given a breast pump at birth, and as soon as the baby is stabilized in NICU, a staff goes to the mother and educates her to start expressing milk by the time the mother is out of the labor table. By third day, there is a reminder that parents need to touch and talk to the baby. The doctor and nurse has to tick that this has been done, and the position assessment tool ensures that babies are placed in flexed midline and also changed positions. By 1 to 2 weeks, there are reminders that we should have started baby to suck at an empty breast if he is stable. KMC also should have started. Oral stimulation also has been started. This process continues till the baby is in the NICU. One such thing which has found popularity and is very useful is kangaroo care, where the baby can hear the mother, feel her touch, smell her. It improves mother's breast milk and should be practiced for longer hours. It requires a lot of commitment from the unit to ensure that long hours KMC should happen. It should be supportive to the mother in the form of privacy, comfort in sitting, and also somebody encouraging and educating the importance of the same. A one step ahead is single room NICUs, where the baby would be getting intensive care in a larger room with the family also there, and the family allowed to live and continue in the way they would have done at home, and baby getting the same environment as would be at home with siblings, parents, grandparents to be around. This is called as couplet care and is catching up in most of the world. Before I conclude, I would remind that this is not just something soft which nurses have to do or which is of secondary importance following hypoglycemia, asphyxia or inotrope management. If you want the baby's brain to grow normally, then you have to give them the right stimulus at the right time, starting from day one in the NICU, and the stimuli being presented at appropriate ages throughout the NICU care. Please remember, if you want the baby's brain to grow in the right direction, then do it before the plant dies. Light is required for the plant, stimulus of the parents is required for the baby's growth. Thank you for your attention. Please remember, together, the nurses, parents, and doctors, we can all make a difference and improve the outcomes of the babies. Thank you so much.
Thanks, Dr. Naveen. In his absence, Dr. Manoj, there are no more questions because the speaker is not there and we can't ask him directly. Dr. Manoj, I can't see any questions in the chat box.
Naveen is there, I think. Naveen is there. He's traveling. That's why he was not sure about the connectivity. Naveen, are you there to answer?
We were asked by our science teacher.
I think the net is fluctuating a lot, so I don't know.
Yeah. You're traveling, Dr. Naveen. So this is a very important area that we have to address in the coming years, this early stimulation program, how maximum we can give care to these young preterm babies. And you know that in our Mahabharata, this Abhimanyu heard these songs and the recitals of this other people, and he knows how to manage. But the final answer was not there. Like that, you have to teach them young from the intrauterine period itself. So people have to address this issue. Neonatologists. So if there are no more questions, let us wind up the session and let's go to, I'm handing over the mic to Dr. Nandakumar, is my co-EB board member. Dr. Nandan, please.
Yeah, sir. Good evening. Good evening. First of all, let me thank the organizers for giving me the opportunity to be a part of this conference. Preterm occupies major portion in any NICU. So prematurity is the major cause for mortality and morbidity in neonatal. A major aspect of preterm care is nutrition, care of nutrition. The next 45 minutes, we are here to a more panel discussion on preterm nutrition. And the moderator is none other than Dr. Umesh Vaidya. Dr. Umesh Vaidya is a doyen in field of neonatology, especially in prenatal nutrition. He is a senior neonatologist at KM Hospital, Pune. The regional medical director, neonatology, Cloudline Hospital, Pune. It's a special area of interest, neonatal intensive care and nutrition and TPA. And the expert panelist, Dr. Femida Paurnami. She is a senior neonatologist in consultant neonatologist KIMS Trivandrum since 2013. Her area of interest is preterm nutrition, respiratory care of extreme preterm neonates. And along with her, we have Dr. Phoebe Francis, the Assistant Professor, Department of Development Tissues. Then Dr. Anantham K.S., Senior Consultant Neonatologist, Kinder Hospital, Cherthala. And Dr. Murali Raj, he's a consultant neonatologist at Kraft Hospital Research Center, Kodungallu. So over to you, sir. Over to Dr. Vaidya. Sir, kindly take over.
Sure. Good evening, everyone. And am I audible properly?
Yes, sir.
Yes. Yeah. And can you see my presentation?
Sir.
Yes. So, good evening, all, and thank you very much for this invite. And we have 45 minutes with us, and I will be going through the most important issues in nutrition that are currently relevant As you understand, preterm nutrition is a huge topic with so many dimensions, but we will not be going through everything. We will just see what is most practical, what is recent, and what is more evidence-based. So I have four wonderful panelists with me, Dr. Femita, Dr. Ananthan, Dr. Francis, and Dr. Murliraj, and welcome to all of you. And I'll just give a very small preamble before we start the panel, that this is how we want our babies to grow. And all babies preterms will have some amount of postnatal weight loss, and after which we would like them to grow like they grew in the intrauterine environment. This usually means that they have to put on around 15 to 20 grams per kg every day. And you can see this particular baby losing some weight, then growing parallel to the lines and coming at the same centile at around 40 weeks. So this is what we desire. But what actually happens is I've shown here. So we picked up 10 random babies, and one of our nutritionists, I told her to just plot all of them on one chart. And you can see, barring this one baby here in orange, most other babies have pretty flat lines here, and they're not so doing well. In a unit which actually boasts of good nutrition and very good practices and strong on TPN and strong on enteral feeds, still we find that babies don't seem to be so well, growing so well. And this seems to be a very global issue, because in the beginning of this century, people have realized that the best nutritional practices that we feel should do well, we are facing this problem globally. So to just start off this panel, this EUGR business that's going on and widely discussed now everywhere in every forum, that why, in spite of we doing so much and we having such nutrition products and we are pushing nutrition so hard, why is this EUGR so common? So my first question goes to Dr. Femita, that how do you define it? Because different people have different definitions. And why are we failing to curtail this EUGR in globally? So Dr. Femita.
Good evening, sir, and thank you. Am I audible, sir?
Yes.
Sir, I'll just start with one sentence. That is that extrauterine growth restriction essentially means an unachieved growth potential of a preterm ex utero. Now, just like sir mentioned, EUGR unfortunately remains very, very common, and its incidence is hard to define and to measure because the definitions used are extremely different worldwide. So most of the authors, that is most of the literature, will quote EUGR as weight at discharge less than 10th centile for that particular postmenstrual age at which you're discharging the baby. There are some reports which even use head circumference, but those are lesser. And some definitions use less sensitive methods like -2 Z scores less than the postmenstrual age weight that is expected. But we at KIMS, sir, have been using a little more sensitive definition, and which we feel is a little more relevant because each baby has a different potential. So what we do is we subtract the Z score of weight for postmenstrual age at discharge from the Z score of weight for postmenstrual age at birth. And if the difference is more than -1 Z, then we call it as EUGR. But unfortunately, if you use this definition, we'll find much higher incidences of EUGR than what is quoted everywhere. So, sir, that's answering one, that there are definitions which are very different, but the most uniform one is less than 10 centile for postmenstrual age.
Right, and they use for various parameters. Some people use it for length, some use it for weight, some use for head circumference. But I think less than 10 percentile for weight at discharge seems to be the most accepted one in most of the places.
Yes, sir.
And why do you think, why can't we control it? What's wrong there?
Yes, sir. So there are a lot of risk factors. So some of them may be called as unmodifiable, like if you have genetics involved, if you have small for gestational age babies, these are things that you probably can't modify much and which will result in EUGR irrespective of what you do. But there are some like maternal abnormalities, maternal disorders, which can be treated early if detected. There are some maternal placental malperfusions which can be detected and the timing of delivery can be made appropriate. Ex utero, there are some comorbidities which we can help with, like severe RDS, longer durations of invasive ventilation, necrotizing enterocolitis, non-standardized feeding regimens, or non-aggressive or non-optimal parenteral nutrition strategies, PDA which is left untreated, and other risk factors that are potentially modifiable. So EUGR remains high because of multiple factors, sir, but there are some in which we can help.
Right. Right, and there are studies that have shown that in spite of maintaining the best caloric and protein intakes, still a significant number of babies still are EUGR. So it's not completely preventable, but you must at least focus on the preventable aspects, have standardized feeding regimens, and try to maximize your nutrition the way that you can. And at our hospital, KUM, we've managed fairly well, and we are able to achieve in utero growth in a few babies. So you can do better than what you have been doing. So Dr. Ananthan, we are talking of EUGR. So what difference does it make? I mean, the baby can always catch up later. So is there any impact of that in the short term or the long term, or why should we worry too much about it?
Yes, sir. Being a premature birth, itself is a nutritional emergency. As we told, despite all the advanced mode of care and proper nutritional managements and protocols in place, we still face EUGR. Just like any other preterm baby or small babies, these babies are prone to have short-term hypothermia issues, electrolyte imbalance, hypoglycemia, increased risk of infections. And in the long term, we are more worried about the brain development, because these babies are coming out in the mid to second to late third trimester. So they are losing out on most of the advantages they received while they were in utero. So as we know that rapid fetal brain growth occurs in the third trimester, like cortical thickening, myelination, axonal development, vascularization, cerebral all happens in the third trimester. So at this vital period, babies are losing out on major macronutrients, micronutrients essential for the brain growth. So studies have found that these babies have delayed cortical maturation at term age, and they can have impaired neurodevelopment in the childhood and adolescence. That is the worrying aspect. Also, these babies are at risk of increased cognitive, behavioral, and motor problems, and maybe 25% of them may have moderate to severe impairment later on. That is one thing. And the other aspect is with the body composition. It has been found that these small babies later on may develop metabolic syndromes, long-term cardiovascular health impairment, and then changes in their body composition. They can have increased adiposity, which later on lead to metabolic syndromes. So these are the main impacts of being a postnatal growth failure in our NICUs.
Right. Thank you so much. You know, this famous study of Stephens, which actually shows that even the first week nutritional intakes can affect your MDI and PDI at 18 months. And that's one of those studies frequently quoted, that how come just short nutritional interventions also in the neonatal period can cause a major impact. Of course, neurocognition stands up to be the most important reason why we need to act early. It's not growth alone, it's the neurocognition that really makes the big difference. So, Dr. Francis, what should be our target for growth in preterms? So we know that achieving in utero growth may be a challenge because we cannot actually mimic the intrauterine environment. But what would be a reasonable target? What would you say is an ideal growth, and what would you say is the minimum acceptable growth for a preterm? And we're talking usually of the small preterms, say 12 or 1300 grammar.
Good evening, sir. Am I audible?
Yeah.
So as we discussed already, it should be like intrauterine growth. It should be in extrauterine life also, it should mimic ideally intrauterine growth. But it is not possible. So always expected a postnatal nadir, and it will be by 6 to 8 days there will be a postnatal weight loss, and then there should be a catch up. So when we are ideally said that it should be 15 to 20 gram per kg per day, but it should be appropriate to according to the postmenstrual age. So if it is less than 34 weeks, we are expecting more. It is around 15 to 22 grams per kg per day. So if it is a postmenstrual age between 34 to 37 weeks, slightly on the lower side, that is around 12 to 15 gram per kg per day. And if after postmenstrual age of 37 weeks or term babies, we are targeting around 25 to 35 gram per day. That is regarding weight. And regarding head circumference and length, initial for extreme terms and all, there will be initially, there is a delay in rising the head circumference and length. So target after first 2 weeks, target will be around 1 centimeter. That's approximately exactly this around 0.9 centimeter per week for head circumference, and for the length also 0.9 centimeter per week. This is the ideal expected growth parameters for with low birth weight or extreme low birth weight babies.
Right. So what I take from your answer is that you don't look at weight alone.
Yes.
Look at the length and head circumference as well. So in these babies, at least weekly in the NICU, when you plot the growth chart, see that the head circumference and length is plotted. And many times our registers have to be reminded to check the length and the head circumference, because weights we usually plot commonly. And as you rightly mentioned, achieving in utero growth is possible, but challenging. But at least you can say no baby should grow less than 10 gram per kg per day, especially in the stable growing phase. So you can try to achieve 15 to 20, but at least no baby should grow less than 10 gram per kg. That would mean that this baby will lead to EUGR. Now, these SGA babies are pretty common. And in our units, we have seen that nearly 40% of babies would have prematurity along with growth restriction. And we may have many of these fetuses, especially multiple gestation. So what is the target for the SGA baby? Because these babies are already small, and should they be growing at the same rate? Or should we have different targets for them in the NICU? This is for Dr. Murli Raj.
Thank you, sir. Thank you, sir, for the opportunity. As you rightly said, the issue of small for gestational age is very high in our NICUs, especially associated pregnancy, associated complications are there, and early birth are there. Many babies are born SGAs. So one thing that I want to highlight is that the growth potential for SGA babies will be less than when compared to the AGA babies, because they have less muscle volume and fat volume, and also the immediate protein accretion may be less in these babies. So what we should aim is a less growth targets for these babies when they are in the NICU. But we have to plot the growth, both the weight, the length, and also head circumference. But our aim is to achieve a steady rate of growth. That is, make sure that the growth velocity is maintained, even though the targets are less than with the AGA babies. So in that case, I think we can make a possible growth curve for those babies.
Right. That's a very good answer. The main issue with SGA babies is globally also we don't have much data, and there is a little bit of confusion about how these babies should grow. But what we surely know is that these babies cannot grow too fast, because we have evidence of metabolic syndrome setting in and adiposity setting in. We don't want them to have more growth restriction because they're already small. So as Dr. Murli Raj rightly said, they don't lose too much weight in the NICU, but they should at least continue to maintain the centile on which they are. So you at least don't push their growth too much, but don't let them fall off the centiles. And I think that is currently the most acceptable mid path for these very small gestation age babies. Now we have a case for this panel. We have a 28-weeker, 710 gram baby, and a very normal story, born by LACS, abnormal Dopplers with growth restriction, absent diastolic flows, the CTG was bad, the cord pH was low, baby required intubation, baby was depressed, had a lung disease, needed surfactant and inotropes. So a growth restricted small baby with abnormal Dopplers with a lung disease, we are going to focus only on the nutrition. So let us ask, we've got a few questions that for Dr. Premita again, that this small baby is just admitted to the NICU. How would you plan the nutritional needs? How would you start the nutritional support? And what difficulties do you think you face when you have a baby of 710 grams who is growth restricted?
So again, I'll just emphasize Anant's answer that nutritional need is as much an emergency as much as you would go behind maintaining saturations or even or managing shock. So it's as important as that. Only thing, you can't see it in the open. You don't have a monitor to look at the SpO2 or something similar to that for nutrition. So early initiation of parenteral nutrition would be a priority, sir, with the baby. And then simultaneously, like Naveen sir had mentioned in the last talk, preparing the mother to express breast milk as soon as she's stable would play a very vital role in procuring mother's own milk early. So we at KIMS give a breast pump personally, and we try to prepare them antenatally unless it's a very big emergency that we couldn't meet her at all. Problems we face may be multiple, sir. It can stem from a lack of uniform policy, or if there's a difference of opinion between clinicians and the unit consultants, or staff nurses may even hesitate to start feeds if the baby's on inotropes. And one needs to give respect to each of their opinions. But if there seems to be no overt contraindication to early feeding, then that should also be as much a priority as a parental nutrition is, sir.
Right. So I think there is no two thoughts about starting parental nutrition. And now, like we talk of the golden hour for resuscitation, now the golden hour here is for nutrition. And I think starting early nutrition will be vital. Everyone would agree that these babies would need early parental nutrition. The controversy is only about what doses of nutrients we would start, and we will follow up with this in the panel. I think one of the problems that we face is intravenous access, because most of these babies at that time are only going to be around, say, 80 to 100 ml per kilo of fluids. So if you want to push them on high protein, then the osmolarity of the fluid really goes up. And sometimes you have to sort of cut down on the protein, because otherwise your proteins would be very high as compared to the amount of fluid that you can give. So venous access and fluid restriction are two problems that we commonly face, but we still try to maximize the protein in whatever fluid that we are able to give this child. Now, the next question is a difficult one, and different units do different things. So Dr. Ananthan, would you start MEN, and when will you start it, how much? And most of the times EBM is not available. So yes, in such a baby who is 710 grams of respirator, when do you think you will start MEN?
MEN or minimal enteral nutrition, also known as trophic feedings or gut priming feeds, is mainly meant at starting small amount of feeds, and the volume has been given by the different units are differ, because initially we can start, some units starts with very small amount like 0.5 ml or 1 ml. We can go up to 10 ml to 20 ml per kg per day in equally divided aliquots every 3 to 6 hours. What we need to know is that this is just a beginning of our step to get the baby to full enteral feeds. So this is going to be a very small volume hypocaloric feeds, and it exerts a trophic effects in the gut mucosa. Animal studies have found that those babies, increases the mucosal mass, it improves the villus growth, reduces the gut inflammation, thereby preventing translocation of bacteria. So there are lots of benefits. Also, it improves the feed intolerance issues, and we can get these small babies into early enteral feeds, maybe by 7 to 10 days of age. And also,
how early would you start it? I mean, the baby like this, maybe the baby needing inotropes, maybe ventilated.
Yes, coming to that. Usually we have to start as early as possible. Within 24 hours we can start, but some people start within 48 hours. So since we are giving only a small volume, we can start with the express breast milk, which is the best one, is the #1 choice. But if you don't have EBM, we can use pasteurized donor human milk. However, there has been literatures where people have used preterm formula as trophic feeds. And also, the main worry is about the risk of NECs, especially in our baby who has had abnormal Doppler, umbilical line in situ, and ventilator. Always there is a worry that if you start feed, this baby may develop neck or not. But it has been found that trophic feeds or minimal enteral feedings, in fact, prevents or reduces the risk of NEC and late onset sepsis. So we should start MEN as early as possible within 24 hours, or preferably within 48 hours, with very small volume of 10 to 20 ml per kg per day, every 3 to 6 hourly. And we have to use, first choice is expressed preterm mother's milk. Second is donor milk. Third comes the preterm formula. And there are no major contraindications. The absolute contraindication for MEN is neck or intestinal obstruction. Rest of the like absent temperature or the baby is stable, with UVC lines are not at all a contraindication starting MEN.
Absolutely, absolutely the right answer. Now the issue is that most of this data that comes is usually for babies above 1 kilo. So babies below 1 kilogram, the data is a very small subset of babies, and people still say that more studies would be needed. Now I am a little brave. I usually start MEN at 6 hours. Actually, the baby is not in shock, and the baby is reasonably stable. I tend to start MEN a little early, and as you rightly said, when you try, you will get some amount of mother's milk, and one can, if you have a milk bank, go for donor milk. And preterm formula, a lot of experts believe that you can give it, though it is not the best thing to give. And recently we had a section of a very preterm baby in our hospital, and the lactation consultant pulled out 17 ml of colostrum right in the recovery room of the theater. So I mean, if you're on the job, if someone pursues it, you really can get mother's milk very early for these very small babies. So in this baby, TPN was started soon after birth. MEN was started around 8 hours of birth. Fluid was 100 ml per kilo. Amino acids 1.5 and lipids 1 gram per kilo. So these were the doses on which this baby was started. And I would ask Dr. Francis, do you think that these doses are okay? It is 1.5 and 1. Are you happy with that? Is it what you do, or you think we should be a little more aggressive? Because in neonatology now, everything is becoming less aggressive and less invasive. Nutrition is the only thing that is getting more and more aggressive with time. So how aggressive can you be? Should you be in the same range for this baby, which I showed, or you think we should be more aggressive with it? And what do you do in your unit?
I will agree with you, sir. We'll start with 1.5 gram per kg per day protein and 1 gram per kg per day lipid. This is
right.
And we'll titrate based on the per day 1 gram per 0.5 to 1 gram per kg per day. But studies have shown that day 1, even 3 gram per kg per day protein can be given. But in our scenario, better preferred with previously it was started on day 1 is 0.5 gram per kg per day, then gradually 0.5 per day was the increment. But currently on the day 1, we are on the high, little on the braver side, 1.5 gram per kg per day of protein, amino acids. Okay.
I belong to that era when we started 0.5 gram and graded up by 0.5 gram every day. And we went to full TPN only by day 5 or day 6. And we started lipids on day 3. So we did practice that in the 80s and the 90s. And now obviously we have moved forward. But what we do at KEM now is that we start with minimum 2 grams per kg of protein and 1 gram per kg of lipid. Especially there is a lot of information that if you have a growth restricted baby, be a little careful with your proteins. Don't load them with proteins very early. And as I already mentioned, there are problems of PDA in these babies, there's fluid restriction, so you may not be able to add 3 gram per kg. So I think I agree with you completely. So 2 and 1 would be a good starting point. And then of course you can grade up pretty fast. You can grade up by 1 gram every day, and depending on the tolerance of the baby. Now, is this baby at risk of NEC? And we know that this baby is on MEN already. And I would now like to ask our panelists that how do you think that we can increase these feeds? And Dr. Muliraj, can you take this question as to how to increase feeds in this baby? And what does the evidence show?
Regarding the first question, is the baby is at the risk of NEC? Yes, the baby is at risk of NEC because the baby is already born preterm 27 weeks. He's an SGA baby, and your scan is showing an absent umbilical artery flow, and he had perinatal asphyxia.
So what do you think would be the incidence in this baby? The normal incidence in an NEC in a unit would be around 5% or 6%. So in this baby, what do you think would be the incidence?
It will be more, sir. It will be, I think it will be some 22 to 25%. The chance is there for NEC is there.
Most studies show that if you have absent diastolic flow and reversal of flows, the NEC incidence can be up to 20%.
Yeah.
So this baby is at great risk of NEC. So considering this factor, how fast would you increase the feeds?
The thing is that the main study that everybody plots is the ADAPT trial, that is the abnormal upper enter prescription trial. And in that case, the less than 29 weeks in growth restricted babies, even if you start the slowest and minimal and slowest hiking of feeds, the chance of feed intolerance is almost same as other baby. The thing is that. So generally speaking, the feed intolerance will be there. The chance of NEC is high. So what I usually do is that we'll start with a lower amount of feeds. That is, instead of 20 ml or 30 ml, I start with the 5 to 10 ml per kg per day, and slowly we'll be hiking. That is, we'll be hiking about say 1 ml every 12th hourly or 2 ml every 12th hourly, and usually we will observe for 3 to 4 days. And by that time, if the baby doesn't develop any signs of feed intolerance or other signs of NEC, after that we'll be hiking the feeds much more faster, so that if the baby remains hemodynamically stable and there is no feed intolerance, he will be reaching, an extreme premature baby will be reaching full feeds by around 7 to 9 or 7 to 10 days.
So it's a perfect answer, and one would definitely start early, but go slowly and be very cautious. And if you've again read the ADAPT carefully, it does recommend that babies below 1 kilo, this may not apply, and more robust information is needed. So we don't have many studies in babies below 1 kilo. That's why we have to be careful. Dr. Ananthan, have you read any recent evidence regarding grading up of feeds in preterm low birth weights?
The one which comes to my mind is SIFT trial,
right,
which is a slow increase in feeding of milk trial, which was done in very preterm babies, less than 1,500 grams, in which they randomized babies into 2 groups. One group received EBM of 18 EBM and formula, which of 18 ml per kg per day, and the other group received a feeding volume of up to 30 ml per kg per day. Their endpoint was to see whether there was any significant incidence of NEC or sepsis, and they could not find any difference between these 2 groups. So confirmed or suspected late onset sepsis or NEC or were not found among these 2 groups. So that is the one study which I would like to quote, sir. Also, there are a few Cochrane meta-analyses as well, in which they have tried different volumes, one more than 30 ml per kg and the other less than 30 ml per kg, but they haven't found any major difference between these 2 groups in incidence of NEC or sepsis.
Ananthan, Umesh Vaidya sir is...
Hello?
Umesh Vaidya sir is, I think, has lost his connection. Sir is there?
Hello?
Maybe he'll just rejoin back. Ananthan, I think we should continue.
Yes. So one of the major worries when we manage these small babies is NEC risk. So the moment we start feeds, that fear is always in the mind, how the baby is going to tolerate the grading up of feeds. So usually in small babies, each units have their own nutritional practices. Some units starts with hourly feeds of small amount and then grade up by like Burley said, 1 ml or 2 ml every 12th hourly or 6th hourly, like that, depending upon how the baby tolerates the feeds. So in a small baby like this, usually my practice is I start with hourly feeds and grade up by 1 ml every 12th hourly, and over the next 2 days, I closely keep a watch on baby's feed tolerance, look for any abdominal distension, any gastric residuals, and any changes in cardiorespiratory instability, like increased episodes of desaturations or any heart rate variation. I will be keeping a close watch. If everything is fine, and in that case, I will keep on grading up the feeds and try to get the baby to at least 120 ml per kg before I take the lines off from this baby and stop TPN. And later on, I'll be supplement this baby with HMF, that too with in a very cautious way, because of the osmolality issues. Probably these babies are at high risk of NEC, so I'll be careful when I start trophic fortifier also in these babies.
Sorry, I just lost my connect. Yeah, I just lost my connect in between. So fortunately, I got the net back again. So I just could not hear part of your answer, but essentially, I would say that most of the evidence in the Cochrane as well as in the SIFT trial, they go mainly in favor of grading up babies faster, and the risk of NEC mortality and other outcomes is not changed. However, one must note that most of these babies were very stable babies. Not a baby like us who was below 1 kilo and very high risk of NEC with abnormal Dopplers. So maybe in such babies, one should still be very cautious, as Dr. Murli mentioned a little while ago. So my question to Dr. Francis is that what is this business of total full enteral feeds? Because we are reading a lot of information now from our country only, where there is no IV, there is no TPN, and even small babies are directly being put onto full enteral feeds at maybe 80 ml per kg right on day 1. So does it apply to all babies? Do you think it gives any advantage, or is there any flip side to this?
These are many studies are from LH Delhi, Professor Nanya. The studies behind the definitely this is early full enteral feeds. That is on the day 1 full enteral feeds by breast milk or even formula, but there won't be any parenteral fluids or nutrition at any point. That is the definition of total full enteral feed. So there is no confusion. We will start full enteral feeds in more than 32 weeks. So that is universally acceptable. And less than 28 weeks, usually we will titrate. That is 20 ml per kg based on the gestation. So the gray area is between 28 to 32 weeks. So between 28 to 32 weeks, or even very low birth weights, that is 1000 to 1500 gram babies. So the concept behind is that as early as we are starting breast milk, there is a gastrointestinal maturity, early maturity, hormonal and secretory level improvement, and also to avoid the side effects of parenteral nutrition, like IV site infections, sepsis. And also early expression and more breast milk early establishment. These are the concepts behind the total early enteral feed practice. But concern is that if there are babies develop feed intolerance, feed aspiration. So studies are basically between 28 to 32 weeks. If they are stable, appropriate for gestation age, no Doppler abnormalities in resource-limited settings. Resource-limited settings where parenteral feeds are not available can try total full enteral feeds. But thing is that we have to anticipate the complications, and there is a risk of small amount of risk of necrotizing enteropholitis. So standard approach, conservative approach is gradual start and progressive increase. But this is the total day 1 aggressive nutrition for preterm babies.
Correct. But Dr. Francis, where to get EBM? On the first day, 80 ml per kg. So the mother is delivered, baby shifted to the NICU, and we say 80 ml per kg. For example, you have got a 1.5 kg, it's going to be 120 ml. So I want 10 ml every 2 hours. So how to get EBM from that mother? And if there's no EBM, would you risk giving a formula to such a baby?
If no mom is not available, pasteurized on a human milk is available, we can give.
Right. So it's better that such practice is done when you have a support of a good human milk bank, because then you can have readily mother's milk available. And I think Dr. Shushma Nangia has done a very, very good work in this area. And she has also used it for babies below 32 weeks, stable babies below 32 weeks. And it's remarkable data and largely applicable to most NICUs, not only the resource poor settings, even the resource rich settings should not waste the resources. And if they can manage this, I think it's good for them. So this baby was being graded up slowly, and usual story, the nurse comes and says 1 ml altered aspirate, a little distension is there, but baby is passing stools and Boyle's loops are slightly visible, baby looks well, what is to be done? And you have so many of these gray areas all the time. And you have these nurses coming to you, and then you're confused as to what is this? What do you exactly call as feed intolerance? And Dr. Femita, is the aspirates or your distension or abdominal girth, or what do you actually do it? And it's such a simple thing, but every unit has a different practice. So what do you think is the evidence and what do you practice in your own unit?
That you mentioned the right word, I think. So it's gray area, as is most things in neonatology. And it can be very, very subjective to assess. It's best to have a consensus within the team. So we, sir, use the definition of presence of significant new onset abdominal distension without even measuring abdominal girth. It's just the look of the abdomen with at least another sign. Like if you have persistent vomiting, that's frank blood or bile in the orogastric tube. If you have hemodynamic new onset instabilities, if you really have NEC signs on the abdominal wall, or if you find baby's not passed stools at all and is looking sick otherwise, then we call it as feed intolerance. Otherwise, if you look at the 5 of us consultants itself within the unit, I am little more aggressive about giving feeds, even if the tummy is looking a bit full. There may be my colleagues who feel, no, we should withhold, or we should maybe go a bit slower. So it is a very gray area, but it's better not to keep stepping down and keep coming down on feeds for every tiny thing. And sir, measuring abdominal girth or doing pre-feed aspirates regularly can be discouraged to a very large extent, because it's got a lot of fallacies. The way you measure the position of the baby in terms of orogastric tube aspirates, everything matters. And the tube itself can cause a bit of trauma, and a small amount of blood inside the tube shouldn't be reason for you to call it bloody aspirate.
Right. So you must really have one unit policy, and other than vomiting, dark green aspirates or hemorrhagic aspirate, most of the other signs are not supported by good evidence. And it is very well accepted now that stable babies with no risk factors, you need not aspirate them regularly. And studies have shown that you don't have to aspirate them, and those, if you don't aspirate them, they reach full feeds earlier. Now, I would just like to know from the organizers how much more time we have on the panel. Can someone please indicate to me? Dr. Nandakumar, how much time do we have?
Seven more minutes.
How much time?
Seven
10
minutes.
Fine. So just let me know when just 2 minutes are left so that we can give the concluding remarks.
Okay.
We'll go through these things a little faster now that this baby was graded up very slowly, 1 ml 12 hourly. We reached 9 ml on day 7. The issue is, again, small babies, NICUs, breast failure rates are very high. So whenever babies come for follow-up, we say, why you're not breastfeeding? She said, no, my baby was in NICU, doctor. So it's assumed that if your baby is in the NICU, then your breasts are going to fail. So how do you sustain lactation in the NICU, Dr. Muraliraj? It's a big challenge for most of us.
Yes, sir. As you rightly said, it's one of the most difficult point of care in NICU to get adequate breast milk, mother's own breast milk in the NICU, especially for preterm babies. So for a term baby, okay, the antenatal checkup and also the third trimester breast examination, all those things, they might be counseled regarding the importance of breast milk, and they may be able to express proper amount of breast milk after delivery. But in the case of preterm birth, all of it happens suddenly, and the doctors or the parents or the mother were not prepared for it. So what we can do is that we can create in the NICU itself, we can create a breast-friendly environment. What we do is we routinely, for all preterm after a preterm delivery, we usually counsel the parents to get a breast pump. The breast pump, it can be manual or electrical, depending upon their financial status, but most of them will buy it. So they'll be able to express more and more breast milk if they get a proper hospital grade electric pump. And if they are not able to do that, they can do manual expression of breast milk also, but there is conflicting data regarding the manual expression. And one other important thing is that the presence of a lactation counselor in the NICU, and also he or she can counsel the mothers regarding the importance of mother's own milk feeding and the proper expression of breastfeeding and giving that milk to the preterm baby. Another important thing too is definitely it is the kangaroo mother care, and that will promote the secretion of breast milk, and my baby can breastfeed as when required. And one of the important thing that I would like to stress is that we are planning nowadays. Every hospital, the we are planning for early discharges. So over-enthusiastic discharges should be discouraged, I think, and before the proper establishment of breast milk production. And also the preterm babies you are discharging, try to put them to breast before discharging from the hospital, rather than train them with a Paladay feed or with a syringe or whatever it is. Make them suck the breast and before discharge.
So absolutely. Excellent answer. And I think I would just say one thing here. Early expression is vital. So many a time the baby comes to NICU, mother is in the postnatal ward or in the other hospital. We must see that she starts expressing early. That has been shown really to sustain lactation. Have a lactation counselor, have a human milk bank if you have a large NICU, or at least team up with some human milk bank. Allow mothers to come in the NICU, give them NNS, give them a kangaroo mother care. And I completely agree with Dr. Buliraj that start suckling the baby on the breast. Even if the baby is on Paladay feed, a little bit of suckling on the breast before giving Paladay. So entire unit to be aligned and pro breastfeeding. And we at KEM Hospital have a lovely human milk bank. And we hardly ever use preterm formula in the NICU. And we are very proud about this aspect. Now, Dr. Fabida, what is this concept that is coming in of this exclusive human milk diet? What is this business?
I'll put it in one line, sir, straight, that it's either mother's own milk or it's pasteurized donor milk from a screened qualified donor.
Right.
With supplemental human milk-based fortifier, sir.
Correct. But you know, human milk-based fortifier only Vijay Mallya can buy, I think now, because the current cost of that is very prohibitive. But I think Vijay Mallya should not say now, because I don't think whether he also can afford it in today's times. But the essential thing is that if babies are at great risk, I have seen that parents are willing to spend, and some are of our very high-risk babies, their parents, if you explain to them, they do agree for using the human milk-based bovine fortifier. Recent comparison between that and the bovine one have shown that the risk of NEC and feed intolerance is less if you use the human milk-based fortifier. Plus, you can start the fortifier early. You can even start it at, say, 30 or 40 ml per kilo. Okay. And of course, a quick question to you only that when you use donor milk versus mother's own milk, can you quickly tell us how it is different? Is there a compromise or are they the same?
There is a compromise, sir. It's the proteins, especially the bioactive proteins, all the immunological properties are reduced dramatically. Lipids are also affected, sir. The calories retain mostly same. And we must remember that this milk comes from mature milk of mothers whose infants are a little older. That will also be a difference, sir. So,
right.
Put it short.
Right. Perfect. Perfect. So I think we have 2 or 3 minutes left now. Dr. Nandakumar.
Yes, sir. Yes, sir. Yes, sir.
Okay, so we will quickly I will just go through this. What is the maximum feed volume that most of us use? I think Dr. Ananthan, you'll agree that this value should be around 200?
Yes, sir. We can go even up to 250, provided baby's respiratory is quite stable, abdomen is okay.
Right. Quick number of calories and proteins?
Calories for less than 1000 gram, we can aim at 120 to 130 kilocalories, and protein of 3.5 to 4.5 grams per kg per day.
Right. Right. And as the babies become bigger, the protein comes down a little and the calories will go up a little. HMF. Now, when should we start HMF?
We can start HMF once the baby is on at least 120 ml per kg per day of feeds. But that volume is some people have even started at a lower volume, like about 50 to 60 ml per kg also, without any harmful effects or bad effects on the baby's tummy. So in unit protocols varies. Most of the units starts at 100 to 120 ml per kg. Absolutely. Usually start with 1 gram sachet. It is available in bovine HMF as well as mother's milk based HMF is also available. We start with 1 gram in 25 ml of express breast milk and give the baby.
Right. And as I mentioned earlier, the human milk based fortifier, you may be able to start it a little earlier because of lesser osmolarity. So this is one of the old studies that I always show, that this study shows 250 to 260 ml per kilo. It's a retrospective old study, 1984. But that time also they showed that babies can tolerate much more. there's no increase in NEC or feed intolerance, and you can achieve optimal growth. So most of us stick to 200, but there has been some old data that suggests that you can go even much higher. So what I think I'll do is that I hand over the proceedings to the chairpersons. There is a lot to discuss, but I think in the interest of time, we have actually covered as much as we could from the NICU point of view. And there were few aspects about long-term follow-up and post-discharge, but I think in the interest of time, we will have to wind up here. We don't want to keep people up very late on a Saturday evening. So I will stop sharing here. I thank all my panelists. All of them have given wonderful answers. And though this has been a very confusing area, you've seen that most of them have given you very evidence-based and practical answers and told us what they practice in the unit. So maybe the post-discharge component we can discuss some other time, and I will not extend the time allotted to me. Again, I thank the organizers, thank all my panelists for this wonderful discussion.
Thank you, sir.
Thank you. Thank you, Umesh Vaidya sir, for this excellent discussion. I think we don't have time for discussion. I think we'll straight away go to this next session. Thank you. Thank you very much.
Sure.
I think one or two questions are.
Hello. It's already, we are running 30 minutes
Nanda,
behind
this
schedule.
is the last session for you. Hello?
Yeah.
Hello?
There are 2 or 3 questions. If we have time, we can discuss. So one question from Dr. Rani Joseph. Is there any amount of free feeds? Some say 25%, some say 50%. Should we stick to or stick on this amount, or will we take any other free feeds with other signs suspecting NIC? Is it necessary to grade up antibiotics, and what about use of metronidazole?
So who would like to take this question among the panelists?
So the pre-feed part, I'll probably just reiterate once again that regular use of pre-feed aspirates is not recommended, and that we would rather just look at the other signs also. If it looks very grossly distended, and if you want to look at it, then you have to have some minimal amount, say 3 to 5 ml, even if the percentage is not the one number that you're going to take. You can't have 1 ml and 0.5 ml as the pre-feed aspirate. Doesn't make sense at all. So if you have given 10 ml and if you get back 10 ml, that's a different issue, sir. So I won't put a single number to it.
Right. So first 3 to 5 ml of feed, there's no need to aspirate at all. In fact, aspirate only when you cross 5 ml, and 50% generally is the most accepted figure in most units. Right. So metronidazole and NEC, I don't think there is much evidence to start metronidazole. We do not do that in our unit. NNS, who would like to take that?
Yeah. What about NNS?
Dr. Murli, would you like to take the NNS question?
Okay, sir. That I already mentioned about this sucking of the breast by the preterm babies in my panel discussion questions. So what is important is about non-nutritive sucking is that it will stimulate the oromotor reflex, and also the babies you'll be able to faster your breast sucking, and the swallowing reflexes will develop faster, and you will be able to put the baby to complete breastfeeds as early as possible. So whenever the babies are hemodynamically stable, whenever the babies are off the breathing support, you can put the babies to non-nutritive sucking. And there is no weight criteria for any non-nutritive sucking. And when the babies are hemodynamically stable, you can start non-nutritive sucking, and it will definitely help.
Right. Who would like to take probiotics? Dr. Ananthan, would you like to take that question on probiotics? Do you use them in your unit?
No, I haven't started using it, sir. There have been a lot of studies coming up about the importance of probiotic of late. About the it has been found to reduce the risk of NEC and late onset sepsis. But the problem is the studies has been done with different forms of lactobacillus and different combination, different doses. So, and all the more it's the use of probiotics in extremely preterm babies also has been raised some concerns about bacterial translocation and infection related to probiotics. So far, jury is still out. We need more studies, and we need to have studies on particular dosage, its availability. All those things need to be more researched, and then only we can start using probiotics here, sir.
Dr. Mulliraj, do you use them in your unit?
No, sir.
No. Dr. Francis? Dr. Famita, do you use it in your unit?
I am not using, sir.
No, sir.
No. So I think Kerala is quite anti-probiotics, looks like. And again, as rightly said, that the final word is not said, but I think most of the data is in favor. If your unit does have babies at high risk of NEC, if your NEC incidence is high, then one may think of using probiotics. Again, no uniform policy. Regarding prokinetics, I can straight away say that prokinetics don't have much role at all in use, and we do not use them. When I was a young student, they used to use a lot of domperidone and metoclopramide in the units for babies who had aspirates. But I think we have moved away from that now, and we usually do not use even erythromycin, which people have used in the past. That also is slowly going out of favor. So I think probiotics, yes or no, and prokinetics, certain no. That would be my take on that. So any more questions?
There is an interesting question by Dr. Jairam Shankar, sir. You can express milk even before delivery by pump if anticipating preterm birth.
Yeah. So I don't know. I've not really ever done it, but does anyone know more about this?
I think there is some practical problems with that.
Yeah. So is anyone aware of this? I mean, some of this practice, I'm not so aware.
Can I add a word?
Yeah, of course.
Actually, one of the doyens who propagated this and who is called probably the mother of breast milk banking in Tamil Nadu, Kumuda Madam, Professor Kumuda, she is the one, like you could now express milk on the mother, I mean the foster mothers on pregnancy. So the concept that was tried to be, I mean, that was actually demonstrated was that it is not just that only the delivery can, the other things are. It's again, I don't think many people have done that, but she has shown that is possible.
Right. Okay.
Will it induce uterine contraction?
That is a concern that.
Sir, if I am wrong, correct me, sir. If you are expecting a preterm delivery and you are stimulating the nipple or breast, can it induce preterm delivery? You want to
the pump, it will not stimulate preterm delivery. Only manual expression will stimulate preterm delivery.
The more challenging will be the obstetricians, whether they will allow us to do such a thing.
They will not allow it.
Practical. There are also practical and political things are also there.
Right. Okay.
So what about starting MEN in child in shock and child is already on anatropes?
Yeah. So again, unless the child is in severe shock and pulseless, and I think there the priority itself is very different, that you have to attend to that shock and that hypoperfusion more than nutrition. So if the child is in frank shock with multiple inotropes, that's one of the relative contraindications for MEN. But not just use of inotropes. Many babies are on an inotrope that their hemodynamics is reasonably stable. I don't think there is any reason to hold back MEN. In fact, studies have shown that if the child is on dopamine and dobutamine, the spasmodic flows are actually better. So unless you're in frank shock and pulseless and DIC and bleeding, I think one can easily start MEN. Okay, there's a question that has come as to what ml per kg of feeds would you start probiotics? We started pretty early. We usually started with the feeds only. So even if the baby is on 2 ml of feeds too early, we would start probiotics pretty early in our unit. And our unit uses probiotics routinely. And I think we are strongly biased in favor of that.
So which probiotic you are using?
We are using Bifidobacterium breve, the rescue net. Monostrain, it's a single strain. Any more questions? We finished the ones in the chat box. So Manoj, are there any other questions?
I don't see any in the chat box, and people must be like, it was a long day. I mean, we
Yes.
started at 2 o'clock, so probably that may be the reason. But then still most of them stayed on. That shows how important this session was and how.
We should now allow them to celebrate rest of the Saturday evening.
Thank you. Thank you. Thank you, sir, and the panelists.
Sure. Okay. Thank you all and good night.
Pramida?
Good night, sir.
Thank you, sir.
Pramida?
Thank you so much, sir.
Thank you.
I conclude. So shall I conclude?
Hello?
Joe, sir.
You
Concluding
can conclude.
sir.
You can conclude.
Okay.
Conclude. You conclude. Conclude.
Okay. So with that excellent session, we have arrived at the end of today's CME and hope all had a wonderful evening, and thank you all for the wonderful support. And let's all meet again at 9 a.m. tomorrow for the second day of our CME. And once again, thank you all and good night.
Thank you so much, Umesh, sir.
Tomorrow morning, we will start the program. Manoj?
9 o'clock, no?
Tomorrow morning, we will
No,
start the
9 o'clock.
program at 9 o'clock. So welcome everybody and invite everybody to join at the right time, because we have to start the program at the right time. Tomorrow we had a hectic time schedule is there. So actually today 1 hour late. Today finished our program. I don't know how far we can able to stick on tomorrow program. We can also have strict compact of scientific content is there. So everybody join at 9 o'clock. We'll, as far as possible, come to we'll plan to keep on the time. And thank you all for joining. Thank you all the faculties for excellent deliberations. All the juniors and seniors giving a good impact, good message to the audience. I think Dr. Manoj, Dr. Devi, Dr. Anandan, Dr. Murali, Dr. Umesh, Dr. Devagar sir, Dr. Naveen Jain, Dr. Nandakumar, Dr. Jaykumar, Dr. Jayaraman TP, and all the members joined for there. Thank you, Dr. Pramida, for comparing the program in a nice way, for coordinating with Dr. Anandan. Thank you all. Good night.
Thank you. Good night.
Good night, sir.
Good night. Good night.
Saturday night banquet ഒന്നുമില്ല sir.
Virtual blanket.
Virtual blanket.
Yeah, blanket. We can start blanket.
Come to the breakout room.
Breakout room like the blanket. Okay. Good night.
ഏതായാലും തകർത്തേട്ടോ പരിപാടി. വെഡിങ്ങിന്റെ പരിപാടിയായിരുന്നു.
വർക്ക്ഷോപ്പ് അല്ലേ?
വർക്ക്ഷോപ്പും എല്ലാം വളരെ നല്ലതായിരുന്നു. പാനൽ ഡിസ്കഷൻ ഒക്കെ വളരെ ലൈവായിട്ട് പോയി.
ടൈം ഒരു ഇതാണ്, സാരമില്ല.
നാളെ വെള്ളം കുടിക്കുന്ന എനിക്ക് തോന്നുന്നു ഇങ്ങനെ പോയാ.
ആക്ച്വലി ഞങ്ങളുടെ പാനൽ ഡിസ്കഷനകത്ത് ഉമേഷ് വൈദ്യ സാർ രണ്ട് മൂന്ന് കോൺട്രവേഴ്സി കൂടെ ഇൻക്ലൂഡ് ചെയ്തിട്ടുണ്ടായിരുന്നു. അവിടെ വന്നിരുന്ന രസമായാനെ. ഞങ്ങളുടെ ഇതിനകത്തെ പ്രീ ടൈം ന്യൂട്രീഷനകത്ത് 2-3 കോൺട്രവേഴ്സി ലാസ്റ്റ് പുള്ളി ഇൻക്ലൂഡ് ചെയ്തിരുന്നു. സപ്പോസ് എന്താ പറയുക MCT
നമ്മൾ വറീഡ് അല്ല, കാരണം നിങ്ങളുടെ ടോപ്പ് ലാസ്റ്റ് ആണ്. അപ്പൊ നിങ്ങൾ എത്ര നീണ്ടുപോയാലും നമുക്ക് ബോധറേഷൻ ഇല്ലായിരുന്നു. ഇതുപോലെ നീണ്ടുപോയാൽ നമുക്ക് പറ്റത്തില്ല.
MCT ഓയില്, പിന്നെ പോസ്റ്റ് നാറ്റൽ ഗ്രോത്ത് റെസ്ട്രിക്ഷൻ ഓഫ് IUGR ബേബീസ്, അങ്ങനത്തെ കുറച്ച് കാര്യങ്ങളും കൂടെ പുള്ളി ഉണ്ടായിരുന്നു. പക്ഷെ അത് നടന്നില്ല.
ഓക്കെ,
ശരി. നാളെ മോർണിംഗ് കാണാം.
Good night.